So
Okay,
we are going live in three, two, one, sir. We are live now.
okay, fine. So let me go. Good morning, everybody. Okay. I think this topic is the leftover from last time's where I could not share my screen. Anyway, now the plan of the talk is first I'll do the pathophysiology of consciousness, followed by a clinical approach to deteriorating level of consciousness, neurological examination of a comatose patients, prognosis and long-term outcome, and then principles of emergent therapy. Time does not permit me to go into the details of therapy, but we'll just outline the principles. Now, in this era of improved resuscitation and support systems, one of the commonest problems facing a clinical neurologist is the assessment, diagnosis, and management of a patient in a state of altered consciousness. Assessment of coma is always a medical emergency, but it is a taxing problem because in a limited time, time is of essence, and therefore in a limited time, the person has to assess the patient, arrive at a prompt diagnosis, order appropriate investigations, and then start appropriate treatment. And often the history is not forthcoming because the patient is found unconscious. Therefore, I think there has to be a systematic examination of this patient, a systematic assessment, arriving at a diagnosis, and then the management. But before I go on to the coma, I'd like to tell you the pathophysiology of consciousness. Consciousness depends on two factors, arousal and the content of consciousness. Arousal is dependent on the ascending reticular formation, which is a group of cells in the rostral brainstem, which projects to the diencephalon and then onto both the hemispheres. Okay? It is the act of coming awake from a deep sleep. The content of consciousness, on the other hand, is the exclusive function of both the hemispheres. It is the function of all the cortical neurons which assess incoming inputs from the environment. So simply put, the content of consciousness is basically awareness of self and your environment. And since it is the exclusive function of all the integrated activity of all the cortical neurons, it produces coherence of thought, intact mental activity, and executive function. Therefore, loss of consciousness has to involve either arousal, content of consciousness, or both. And this can result in three pathological states. The patient is awake and aware, which is the normal state. The patient is awake, that means the reticular system is intact, but the patient is not aware, therefore the content of consciousness is affected. Or the patient is not awake and not aware, in which the reticular activating system as well as the hemispheres are affected. Now, there is only one abnormal condition in which the patient is awake and aware, but he has no motor activity below the eyes, and that is the locked-in syndrome. Now, when a disease process affects the nervous system, the level of consciousness deteriorates. And this deterioration can be judged by two parameters, namely the cognitive function as well as the motor function. In the initial stages, there is hypersomnia. So as the name suggests, that the patient sleeps excessively. And if disturbed, he can be aroused, but then again lapses into a deep sleep. If there's further deterioration, the patient goes into an acute confusional state in which the patient is totally confused, disorientated, etc., but is awake. Okay? And he may have lapses of memory. That means he may not be able to recall part of the day or the location where he is. And a prominent feature of that is distractibility and no coherence of conversation. Further deterioration may result also in delirium. Delirium is nothing but an acute confusional state in which you add hallucinations and systemic manifestations of confusion. Now, in this state, there is a diffuse cortical impairment and the brain misinterprets all sensory inputs with inappropriate excitement. The systemic manifestations in this condition of delirium are predominantly autonomic and results in tachypnea, tachycardia, hypertension, and sweating. So if you have a patient whose acute confusional state, together with systemic manifestations and hallucinations, it is delirium. Further deterioration will result in a severe cognitive disability or akinetic mute state. Further deterioration results in stupor and then coma. If the coma is extremely prolonged and irreversible, it results in brain death. If the coma is severe but partly reversible, it results in a persistent vegetative state. And if it's less severe, it can result in a minimal cognitive state. So very often, these changes in the level of consciousness can be seen when a patient is recovering from coma. So in a reverse order, if the patient recovers from coma, you may have a persistent vegetative state, minimally conscious state, sometimes akinetic mutism, confusional delirium, hypersomnia, and then they become normal. Now, as I mentioned, if the patient is awake but not aware, you have acute confusional state, delirium, akinetic mutism, minimally conscious state, and persistent vegetative state. I've already talked about this. They have impairment of attention, memory, logical thinking, recall, prominent distractibility, and no coherent conversation. Delirium is add hallucinations and systemic manifestations, and I've already talked about this. Akinetic mutism, as the name suggests, is motor function is totally akinetic. There's hardly any motor function. And the speech output is absent, therefore mutism. It is a seeming wakefulness without any content. There's a relative paucity. Please remember this. There's a relative paucity of corticospinal signs. And that is how, if you have a patient with very mild or hardly any corticospinal signs, but appears awake without any speech output, it's an akinetic mutism. These patients can have arousal, they can have sleep-wake cycles, respiration is preserved, and awareness is partial. They have spontaneous eye opening, but visual tracking is impaired. Okay, and this is usually due to lesions of the medial frontal lobe limbic system and diffuse bilateral hemispheric involvement. Now we come to the main content of this talk, that is stupor and coma. Now stupor, best put, is a pre-comatose stage. It resembles extremely deep sleep. So if you respond to vigorous stimulation, painful stimulation over the sternum or supraorbital area, the patient may have limited motor activity. But once you stop the painful or noxious stimulus, the patient ceases, the stimulus ceases, and the patient lapses back into a sleep-like state. Now, it has to be differentiated from psychogenic unresponsiveness. And the best way to do that is the first two things. If you have psychogenic unresponsiveness, if you try to open the eyelids, open the eyes, there is resistance to opening of the eyelids. And the second thing, there's an absence of any neurological deficits. Okay. Further things, you can try out optokinetic nystagmus, or ice cold calorics will produce a nystagmus, or you can do an EEG, which will be normal. But if you look at these two factors at the bedside, you can very easily differentiate stupor from psychogenic unresponsiveness. Now we come to the main part of this lecture, that is coma. It is a state of unresponsiveness. The eyes are usually closed, but please remember, rarely the eyes may open to pain, but there is usually no tracking or fixation. The patient cannot be aroused, and the motor responses are reflex, meaning in a lighter coma, it may be in inflection, arms, upper limbs may be in flexion. As the coma deepens, the upper limbs will go into an extensor thrust, or ultimately when there's tonsillar herniation, the patient goes totally flaccid. If the coma is transient and less severe, as I mentioned, minimally cognitive state. If the transient and more severe, persistent vegetative state, and the coma is severe and irreversible, it results in brain death. Now, all of you know that a supratentorial or infratentorial lesions can produce coma. Okay, and I need not dwell on this slide further. The etiologies of coma. This is a review of 14 studies which were done between 1981 and 2013, 33 years, and involves studies from Europe, US, UK, Japan, and Africa. And if you see, the main etiologies are strokes and post-anoxic encephalopathy. Poisoning and metabolic depends on the country in which you're seeing the data. However, in African countries and developing countries, CNS infection form a large percentage of the coma. So this slide essentially is important for this factor, that in developing countries, infections do play a large part in the etiology of coma. Now, these are the sites of cerebral herniation. On the left-hand side is a cartoon which shows you number one is actually uncal herniation. Number two is rostral to caudal herniation. Number three is transfalcian herniation. Number four is herniation through a burr hole. Number five is reverse herniation, upward herniation of the cerebellum. And number six is tonsillar herniation. In the middle column, you can see CT scans. The top CT scan shows you not only transfalcian herniation, but also uncal herniation. Here, the middle one shows you uncal herniation. And the lower one shows you all the effects of herniation, including tonsillar herniation. And you can see on the right-hand side, durate hemorrhages. These are all pathological specimens which I have collected over the years from JJ Hospital. Okay, here you see transfalcian herniation, uncle herniation, and rostral to caudal herniation with tonsillar herniation. Therefore, before the patient lapses into a deep coma and has tonsillar herniation, you have to recognize the early stages of this coma. The early stages of central herniation, that is rostral to caudal herniation. The first step is long cycle child stroke respiration. The pupils become small but are still reactive. And if you try the ciliospinal reflex, ipsilateral dilatation of the pupil is present. Upward gaze gets impaired very early because it is a factor of the midbrain, and very early herniation will affect the midbrain. But horizontal ocular movements may still be present on oculocephalic maneuver. The patient may localize pain, or there is a flexion response to pain. Okay. Now, if adequate treatment is not done, then the patient goes into the late stages of central herniation, in which you have short cycle hyperventilation or giant stroke respiration. The pupils become mid position or dilated, but they are fixed. Okay, there's a loss of horizontal oculocephalic maneuver or ocular vestibular reflex. And from flexion, the patient goes to extension to pain and then results in total flaccidity, at which stage it is too late, as seen in this MRI, or CT scan. You can see a massive infarct of the internal carotid artery and with a total infarcted hemisphere. The uncal herniation. Please remember the uncus herniates and compresses the midbrain. So initially there is regular but rapid respiration. And there is ipsilateral third nerve palsy. Okay, it may be partial or it may be total. Okay, there's early loss of oculocephalic maneuver and ocular vestibular reflexes. And there is unilateral or bilateral pyramidal signs. I often teach the patients that if there is a patient with a left-sided hemiplegia as shown in this figure, don't test the plantar on the left-hand side. Test the plantar on the right-hand side. Because if there's extensor plantar on the right-hand side, these are very early features of uncal herniation and your red flags should go up. Now you can see in this MRI that the uncal herniation is compressing the midbrain. And even here you can see the enlarged temporal uncus of the temporal lobe compressing, early compression of the midbrain. Okay, once that is not treated and you get something like this, where there's a massive uncal herniation and the whole of the midbrain is compressed, you'll get short cycle giant stroke or hyperventilation. There'll be a total ipsilateral third nerve palsy, and the rest of the features merge with central herniation. That means loss of oculocephalic maneuver, loss of ocular vestibular reflexes with a total third nerve palsy. And from flexion, they go into extension or total flaccidity. By that time, I think it is too late to help the patient. Therefore, my plea to the postgraduate students, please pay attention to the early stages of central herniation and to the early stages of uncal herniation. don't allow the patient to go into the late stages. Okay. Now, as you know, coma can result from an infratentorial lesion. The only difference from supratentorial is that they can be small, discrete brainstem lesions. Okay. The early signs may be missed. What are the early signs? There may be early signs of ataxia from involvement of the cerebellum or its connections. There may be early signs of external ocular movements, mean early absence of oculocephalic maneuver or ocular vestibular reflexes. And the etiologies are usually cerebellar or brainstem hemorrhages or infarcts. Rarely you can have abscesses, granulomas, or tumors. Okay, but for the neurologist, brainstem hemorrhages and infarcts is important. And this slide shows you one of my patients' 3 sequences on the MRI of a midbrain infarct. And on the right-hand side is a CT scan of a midbrain hemorrhage, which outlines total hemorrhage. And this patient died within 12 hours of admission. It's not surprising that he died because you can see the whole midbrain is covered in blood. However, I would like to stress here on the pseudotumoral cerebellar infarcts. Now, you all are always taught that treatable conditions should gain importance. And this is one of the treatable conditions. And therefore, you must act rapidly in these cases. They are usually large, complete pica infarcts, which involve the cerebellar hemisphere. Okay, the initial symptoms may be non-specific to the cerebellum, namely headaches and incessant vomiting. The ocular signs may be a unilateral gaze or a sixth nerve palsy, or it may be a bilateral horizontal gaze palsy, in which case you can find only vertical eye movements in the form of ocular bobbing. The patient remains drowsy or may lapse into stupor or coma over 24 hours. If this is not recognized, an action is not taken. The initial CT scan may be normal in about 25%, but nowadays, who does a CT scan under these conditions? The most important part is that if a patient lapses into coma, 85% will die without surgery. However, if the patient lapses into coma, 50% will have a good outcome if you do the surgery. And what is the surgery? The surgery is simply suboccipital decompression. Therefore, do not allow your patients to lapse into coma. Recognize such patients when they are drowsy or stuporous and do the surgery. And that has a very heartwarming results. You look at these patients, large infarct on the top, also on the right-hand side. And in the bottom, there's a hemorrhage. All these patients you see in the latter slide, the suboccipital decompression, and the patients have removed to independent normal activity. So I think Azad may remember one such patient in which we had advised suboccipital decompression with very gratifying results. Now, the second thing that I would like to impress about posterior fossa is brainstem depression due to sedative drugs or intoxication. Herein lies the danger of the uninitiated neurologist, lack of experience, or whatever you want to call it. There lies the danger of premature diagnosis of brain death, because all the brainstem reflexes may be absent. Now, when you suspect that the brainstem depression is there because of a premature or because of sedative drugs or intoxication, there are two pointers that are very useful. The first pointer is that the pupillary and corneal reflexes are usually preserved out of proportion to horizontal oculocephalic maneuver or oculovestibular reflexes. And often I have pointed out to many of the intensivists, okay, please rule out sedative drugs, usually anti-epileptic drugs, which sometimes knock off the horizontal oculocephalic maneuver and oculovestibular reflexes. Now, when you suspect this, what you should do is a unilateral ice-cold water caloric test. And you'll find that there's upward gaze deviation of both the eyes. Now, please remember that these sedative drugs knock off the median longitudinal fasciculus. And therefore, horizontal oculocephalic maneuver, oculovestibular reflexes are totally absent because of a physiological knockoff of the median longitudinal fasciculus by the sedative drugs. But they do not require vertical eye movements or verticular deviation of the eyes, does not require the median longitudinal fasciculus. It is a function from the midbrain, from the cortex to the midbrain. And therefore, a unilateral ice-cold caloric will produce upward gaze deviation. Okay, there's a little caveat to that, that when you suspect this, you must raise the head by about 30 degrees so that the horizontal semicircular canal becomes totally vertical. And then you irrigate the ear and you find that upward gaze deviation. If that is so, please send the blood parameters for any sedative drugs and do not bother to test for brain death. Now, once you have done all this, you must begin the neurological examination in a systematic fashion. Please remember that in a comatose patient, you have to judge reflex activity because the patient cannot cooperate for voluntary activity. So first thing is to judge the position, the posture, spontaneous movements. Okay. Now, if you do that, you will definitely get any focal signs will be very evident in a patient. And usually if the cause of the coma is a stroke, whether hemorrhagic or ischemic, that will be very obvious. The second thing is to judge the respiratory pattern. Now, in the past, various types of respiratory pattern have been described based on the level of the lesion. For example, in the diencephalon, you get Cheyne-Stokes respiration. In the midbrain, hyperventilation. In the rostral pons, you get a peculiar breathing pattern called apneusis, where the patient holds his breath in deep inspiration for a while and then expiration occurs. Okay, like this. Deep inspiration, then holds the breath and then expiration. If your lower pons, you get ataxia, and then in the medulla, you get a respiratory arrest. Now, I think these patterns have been overestimated because in real life, in real time, you don't get such clear-cut demarcation of lesions. And secondly, with modern respiratory assisted ventilation, I think recognizing all these respiratory patterns becomes a superfluous task. And therefore, in this modern era of assisted ventilation, I would request you to just forget about the respiratory patterns. So once we've ruled out respiratory patterns, the patient may be intubated and on a ventilator. You have to rule out a fracture of the skull or the spine. And then you check out for neck stiffness. How do you rule out? Either you have an X-ray or you look for the battle sign. The battle sign is ecchymosis in the distribution of the posterior auricular artery with discoloration or ecchymosis near the tip of the mastoid process. This is one of my patients who had this. You can see the ecchymosis. And we had maintained the patient with a cervical collar because of the fracture. Under these circumstances, please don't attempt to check out for neck stiffness. You'll only make the matter worse. Once you've done that, you look at the fundus. And what do you check out in the fundus? You check out for signs of hypertension. You check out for signs of diabetic retinopathy, particularly in patients of stroke. And you check out for signs of subarachnoid hemorrhage. And what are those signs? That's a subhyaloid hemorrhage. That is a subhyaloid hemorrhage. You will see a level of blood. All right. If you see this, the diagnosis of subarachnoid hemorrhage is confirmed. You need not bother about doing a lumbar puncture. You can directly go into a DSA to check out whether the subarachnoid hemorrhage is due to an aneurysm or not. Once you've done that fundal examination, you check for levels of consciousness, signs of lateralization, and brainstem activity. Now, levels of consciousness is Glasgow Coma scale. All of you are aware of this, so I need not dwell on it much further, except to say that if you have no activity, nil, you still have a score of 1, both in eye-opening, motor response, as well as verbal response. And therefore, if you are brain dead, you still have a score of 3, which is the fallacy of the Glasgow Coma scale. But there is a new scale which is called the 4-score full outline of unresponsiveness. It is similar to the Glasgow Coma scale in eyes and in motor activity, but it does not take the verbal response into account. Instead of that, it has brainstem activity, which deals with the pupillary reflex, the corneal reflex, and in the ultimate stages, the cough reflex. It also deals with the respiratory pattern, which is in the first 3, the patient is not intubated, and in the latter 2, the patient is intubated. You look at its normal pattern, giant stroke breathing, irregular respiration. If the patient is intubated, he has a respiratory rate above the ventilator rate, therefore he's fighting the ventilator. And if he's not fighting the ventilator, there's usually apnea. Okay, so this is a better score, but it is an under-recognized score. Now, this slide is particularly important, and I would like you all to pay attention to it. There are 6 points that I would like to make. And all these points are based on just observing the patient. It does not require any detailed monitoring or examination of the patient. The first thing is that if you denote weakness, or if the patient has a grasp reflex, or the patient has focal seizures like epilepsy partialis continua, you have a very good lateralizing sign. Secondly, if the patient is plucking or clutching at his clothes and is very agitated, at least you know he has intact corticospinal tracts. The third thing, the reaction to painful stimuli. And very often, the students who have seen me examining a drowsy patient or a comatose patient, if the patient grimaces, I make a note about it because it means that there's intact corticobulbar tracts up to the pons. That is the facial nerve. Grimacing is a voluntary movement. to a noxious stimulus. It is not a reflex movement. And therefore, there's intact corticobulbar tracts up to the pons. If you have roving eye movements, if you're observing roving eye movements, the pons, the midbrain, and the connection between them, that is the median longitudinal fasciculus, is intact. If you have multifocal myoclonus, it either means that the etiology is hypoxic ischemic or a metabolic encephalopathy. And lastly, if you see orofacial dyskinesis, the patient has metabolic encephalopathy. Now, for those who want to photograph this slide, can now photograph this slide. As you see, these are very simple observations, but they give you a lot of data in localization as well as what is involved and what is not involved. Lastly, the brainstem functions, you judge the pupillary reaction, corneal, spontaneous eye movements, reflex eye movements, etc. All of you are well aware of it. And this comes in deep coma, and you have to judge whether the patient is heading for brain death or not. When you're looking at the pupillary reaction, my plea is also look at the position of the upper eyelid and look for any edema of the eyelid to suggest trauma. Now, once you've done this examination, you can divide your patients into three main groups. Coma with focal signs. Remember that I gave you lateralization of weakness, grasp reflex, or epilepsy partialis continua. Coma without focal signs, but with meningeal signs. And coma without focal or without meningeal signs. So please keep that in mind. The first three things I told you to remember is the patient awake and aware, awake but not aware, not awake and not aware. And once you've done your physical examination, coma with focal signs, coma without focal signs but meningeal signs, and coma without focal or without meningeal signs. Now the neurologist will essentially be faced with number 3. Okay. Now, as you know, focal trauma, I won't go much into these details because all of you are aware of them. Neither here, these are all CT scans or MRIs of focal lesions. You have coma without focal, but with meningeal signs. If it is associated with fever, it is meningitis or encephalitis. Without fever, it's subarachnoid hemorrhage or diffuse trauma, traumatic brain injury with subarachnoid hemorrhage. Now, I won't go into this latter part. That was in the era where we did not have CT scans or MRIs. Sometimes a midline posterior fossa tumor produced an acute rise of intracranial pressure with hydrocephalus, and the stretch of the dura and meninges in the posterior fossa may give a false meningeal signs. Okay. Now, these are just patients of ethmoid sinus defect, ventriculitis, CSF showing pyogenic meningitis together with spinal meningitis, and another patient with ventriculitis, and subarachnoid hemorrhage due to an aneurysm which was coiled. Okay, now we come to this. This is the bread and butter diagnosis for a neurologist. Anoxic ischemic encephalopathy, which is very easy because you have a history of cardiac arrest with resuscitation. Metabolic encephalopathies, diabetic, uremic, etc. Toxic encephalopathy with fever, septicemia. You can have non-convulsive status epilepticus. You have drugs, intoxication or poisoning, and hypo or hypothermic brain damage. Now, let me have a word of non-convulsive status epilepticus. It is status epilepticus without prominent motor symptoms. Sometimes the symptoms may vary from mild confusion to coma. The negative symptoms may be that of aphasia, mutism, of amnesia. And the positive symptoms may be tonic eye deviation to one side or nystagmoid jerking of the eyes. In a study where EEG monitoring was done in COMA, video monitoring, 8 to 20% had non-convulsive status epilepticus. And the common underlying diagnosis in those cases was strokes, subarachnoid hemorrhage, infections, traumatic brain injury, anoxic ischemic encephalopathy, and toxic metabolic encephalopathy, sepsis. Now, there are also drug-induced non-convulsive status epilepticus, and those are multi-agent chemotherapy and beta-lactam antibiotics in a patient of CKD. Therefore, if you have any unexplained alteration in behavior or consciousness, please order an EEG. The tendency of modern intensivists is to order a neuroimage. But I think if you have non-convulsive status epilepticus, please, you have to get an EEG so that you can start the treatment if you establish a non-convulsive status epilepticus. The second thing that I'd like to stress is there are drug-induced seizures and coma. Now, on the left-hand side are all the common antibiotics that are used in the ICU. And you see the side effects of all these antibiotics or adverse effects of these antibiotics. They can produce an encephalopathy, they can produce seizures. Cephalosporin, carbapenems, and quinolones are rather notorious for that. They can produce non-convulsive status epilepticus, usually cephalosporins, piperacillin, tazobactam, and quinolones. They can produce delirium and psychosis, particularly quinolones. And lastly, and now what is the risk factors in that? These usually occur in the elderly with renal failure, prior CNS disease, or in the case of metronidazole, hepatic failure. However, there is one condition in which there is drug-induced coma, and that is with cefepime. Now that occurs, if you're giving cefepime, it occurs 1 to 10 days after the administration of cefepime, and it takes 2 to 7 days for resolution. Now, if you're not aware of this entity, you can order for obscene number of investigations, all of them will come out negative. And if you miss the bus, it will be disastrous for the patient. However, if you recognize this entity and you withdraw cefepime, the patient may come out of the coma within 2 to 7 days. Okay, so that is the importance of this slide. Now, let me give you an example. This was a 72-year-old female with chronic kidney disease. Her husband was a senior orthopedic surgeon, and he was in the ICU with her, conversing with her, and then he says, I better go home now, rest, and he said goodbye to her. And she did not respond. So he got suspicious. She had open eyes. She looked away, but she was not aware. She was totally unresponsive and then lapsed into a stupor. She was being given cefotaxime for her urinary tract infection or some infection. I don't remember. And when the reference was made to me, he was very sure that she suddenly turned unresponsive. So we ordered for an EEG and it showed a non-convulsive status epilepticus. She was treated for that, and by the 9th of January 2008, she became totally conscious, aware, and back to baseline. So please remember drugs, and please remember not convulsive status epilepticus. Now, what is the prognosis of coma? It depends on the etiology. traumatic comas have a much better prognosis than non-traumatic comas. The duration and severity of the disease process. For example, if the cardiac arrest is hardly for 5 minutes, the prognosis is good. If the cardiac arrest is prolonged and resuscitation is prolonged for 35 minutes and whatnot, the prognosis is bad. If the etiology is some type of an infection, say herpes simplex encephalitis, and it is a very massive infection, I have seen at autopsy the whole temporal lobe coming out piecemeal. So the prognosis also depends on the severity of the etiology. Then amongst the examination, the pupillary light reflex, the corneal reflex, the oculocephalic maneuver, and the oculovestibular reflex. Add to that the motor response. If the motor response is flaccidity, bad prognosis. If it's reflex in extension, guarded prognosis. Reflex action in flexion, better prognosis. And if the localization is appropriate, the prognosis is good. So you have to take a combination of the above four. For example, the prognosis at day 1, a good outcome is judged by the brainstem reflex. If the pupillary reflex comes back, corneal comes back, and the person has purposeful movements, it's a good thing. If you do the ice-cold caloric, and if you get nystagmus, it's a very favorable prognosis. Because normally in coma, we will get tonic deviation of the eyes. But if you get nystagmus, that means the PPRF has started functioning and is generating saccadic movements, which are part of the nystagmus. Now, a poor outcome is where all the brainstem reflexes are absent and there is flaccidity and no reflex activity. Now, people have judged with the EEG, evoked potentials, and there is a recent paper in Lancet, in JAMA Neurology, where they have done a host of biomarkers, including neuronal specific enolase, neurofilament light, glial fibrillary acidic protein, many other things. And what they have found out that these biomarkers are elevated essentially in very severe cases where not only the cortical mantle is involved, but also the subcortical white matter is involved. And under those circumstances, the MRI and more importantly, the clinical findings have a better sensitivity than these biomarkers. Lastly, the principles of emergent therapy ensure and maintain ABC, airway, breathing and circulation, adequate nutrition. Don't forget about vitamins. Please give them B1, B6, B12 initial. Many of these patients with Kwashiorkor may come out, not Kwashiorkor. Yeah. Then lower the intracranial pressure, control seizures and infection, particularly non-convulsive. Maintain fluid, electrolyte, and acid-base balance. If there's poisoning, gives a specific antidote. Control agitation and pain. Please don't forget, control pain. The patient should not get agitated with pain. And lastly, please protect the eyes. If there's prolonged coma, I have very often done a stitch in the upper eyelid, pull the thing down with a silk suture and tape the suture at the upper zygoma arch and protect the eyes. This is particularly important when patients are not in coma, but in a pseudo coma of Guillain-Barré. I've seen many patients come out of coma with an exposure keratitis and impaired vision. So these are the points that I would like to stress. and thank you. I'll stop sharing.
Yeah. So, as per expectation, it's an amazing discussion on COMA, clinical approach, and the important things what not to miss, where not to make a blunder, because a blunder in the management of COMA will have catastrophic problem. So Dr. Karthik has requested that he would like a break between the first talk and the second talk.
No,
Is it right?
no, Ashok,
Yeah?
I'd rather go on with my second talk.
All right, fine, because it requested Amna, so fine. So please, sir, please start with the second talk on TBM.
Yeah, just give me a minute.
Yeah.
I have
So
to get mine.
you will be aware that the most important work that introducing the correlation between HIV and CNS tuberculosis was done by Dr. Karthik and JJ. And those papers are discussed and mentioned in each and every textbook on stroke and on TBM and correlation between the two, and what the role of impact of HIV has on stroke and TBM and management. Yes, sir. So please go ahead with.
Yeah, I'm just trying to get my slides in order.
All right. All right, sir.
Ashok, I'd just like to say we've listened to this lecture. At least I've listened to it 2-3 times, but every time, it is so terrifically impressive. And so many things, like for example, this brains, the uncle and the central. One, you look at the early signs. You look for the opposite plantar, you look for the dilated pupil, and the other side, you look at the upgaze. You see? Fantastic. Absolutely fantastic.
I like best for COMA with focal, COMA without focal.
Yeah. Yeah.
Clean. There's no bullshit about it.
And subhyaloid hemorrhage, I've never seen a picture slide so beautiful as this.
Absolutely.
Yeah? This semi-lunar type of a thing.
Sorry, can the support system guide me? No, you all can't see my slides, no?
No, sir.
Share screen. Sorry, I mucked up something. Now, can it be seen?
Now we can see the CNS TB 2022.
Right.
I need to click on that, sir.
CNS TB 2022.
Yes, sir.
But not
You
the slide.
highlighted it. You have to click it, I think.
I don't know. It's not showing on my thing.
We can see this. Below this was coma in the nahi.
Just, I better go to this. Share screen. CNS TV. What is this now? Yeah, that is the one. Okay. Let me close that. Shit.
So, yes, that's right. Now we click on that. Yeah,
Now,
that's right. That's right.
Yeah, got it, got it.
now,
Okay.
Perfect.
okay, fine.
Yeah.
Okay, now, I managed to revise this yesterday
Wow.
and bring it up to date as much as I can. Now, this talk is very based on my review article on CNS tuberculosis in Journal of Neurological Sciences, 2021. Okay. Now, let us begin with the epidemiology of tuberculosis. The WHO Global Tuberculosis Control Report 2018, which was brought out in 2020, shows that Mycobacterium tuberculosis infects over 2 billion individuals worldwide. However, only 10% of those develop active tuberculosis. But if you take 2 billion, it amounts to 10%, amounts to 200 million people. In 2017, approximately 10 million new cases of TB were detected worldwide, and there were 1.6 million deaths. Fortunately, the death rate has fallen by 29% since the year 2000 with the WHO Stop TB program. Now, 8 countries, India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa, have 66% of the global burden, of which India has 27%, and therefore it is the capital of tuberculosis in the world. TB kills more people in India than AIDS, STD, malaria, communicable diseases combined. And since AIDS has come under control, TB is now the leading cause of death by a single infectious agent. Now, there are a few characteristics of this Mycobacterium tuberculosis. The Mycobacteria species are tuberculosis, avium, bovis, and africanus. However, practically almost all of human infection is due to Mycobacterium tuberculosis, which is a gram-positive, aerobic, non-motile, non-spore forming large bacteria. It is one of the largest bacteria. It is 2.2 to 4 micromillimeters. It has a very slow growth in vivo and cultures. And that is the reason why the cultures take such a long period to come out positive. It has a cell wall which is very rich in lipids, glycolipids, and sugars. And that is the reason why it hardly stains with the gram stain. Okay. And this is what protects it from the entry of antibiotics within it. And therefore it becomes resistant to antibiotics. Besides that, it has specified antibiotic resistant genes. Okay. And it has the capacity to synthesize all its essential nutrition. And therefore it is not dependent on the host metabolism. Therefore, you see from all these characteristics that we are dealing with a very deadly pathogen. Now, CNS tuberculosis, the clinical profile, as you all know, is meningitis, which forms about 80 to 90% of cases of CNS tuberculosis. intracranial spinal meningitis, which is nowadays, I think, is a rarity. I've hardly seen it anymore. During my residency days and during my early days of practice at JJ Hospital, we used to see. But nowadays, somehow or the other, I've not seen primary or secondary spinal meningitis. Intracranial tuberculomas associated with TB meningitis or independently, fairly common. Tuberculous abscesses, not so common. And a combination or two or more of the above. Now, the clinical features is that there's a prodromal stage in which the patient has vague ill health, lack of appetite, loss of weight, no energy, fatigue, and night sweats. This stage may last for several weeks or months. And then comes the stage of acute meningeal involvement, or in my experience, sometimes there's low-grade glumbling meningitis. And this I call acute on chronic meningitis. And let me give you an example. On the left-hand side is this lady's first CT scan in November 1988, where she was seen by a very senior and extremely good neurologist for headaches. Nothing was found on examination or on the CT scan, and she was just given symptomatic treatment. 7 months later, she presented to me with acute headaches, fever, vomiting, and cranial nerve palsies. And look at the massive basal meningitis that she had. I've used this example several times to stress that sometimes it may be a low-grade grumbling meningitis and then suddenly flares up as an acute meningitis. Now, this is not acute. The basal adhesions are not acute. They have taken time to evolve. And therefore, it was a low-grade grumbling meningitis, and for some reason, it flared up. Now, the stages of acute meningitis, I will dwell only on the adults. You have fever and you have headaches. In adults, nausea, vomiting, apathy is not much. Seizures also are not much. Past history of TB may or may not be there. They don't flare up with a precipitating illness. There is meningeal irritation, there is focal deficit, and patients can go into coma if the diagnosis is not made early. However, in children, nausea, vomiting, apathy, seizures, past history of TB, meningeal irritation, and coma stand out predominantly. Okay? And therefore, these things have to be taken into account in the stages of acute meningeal irritation. Now, in the year 2000, we published this data on the clinical, radiological, and pathological profile of tubercle meningitis in patients with and without human immunodeficiency virus infection. Now, what were her findings? We had 33 cases of HIV negative and 22 cases of HIV positive. The duration of the illness, there was no significant differences. The symptoms and signs, no significant differences, except cognition was definitely affected, significantly affected in the HIV positive individuals. Stages of the disease was worse in the HIV positive. So for the same duration of illness, the staging was much worse and the mortality was much higher. Therefore, you have the same duration, the same set of symptoms and signs, but more deteriorated and died. Therefore, I claim that the TBM with HIV positive, or the new TBM, as I called it, was a fast motion version of the TBM in HIV negative. This I took from the slow virus. the slow virus illness was described as a slow motion version of an acute encephalitis. So using that same corollary, I feel TB meningitis in HIV positive individuals was a fast motion version of the TB meningitis in HIV negative individuals. Now, the diagnosis of TB. The critical clinical issue is making a rapid and accurate diagnosis. Now, please remember that all the bad results of treatment of tuberculous meningitis is because of a delay in starting therapy or delay in not making the diagnosis. So if you do the lumbar puncture, it is predominantly lymphocytic leukocytosis. There's elevated protein and the plasma, CSF to plasma glucose is less than 50%. However, for the latter, please remember, it takes about 2 to 3 hours for the blood sugar or the plasma glucose to stabilize in the CSF. Therefore, doing a simultaneous blood sugar and lumbar puncture is a wrong way of doing it. You must do the blood sugar at least 2 hours before and then do the lumbar puncture. Okay. Now, what are the practice guidelines? The practice guidelines in India is that if you have a consistent clinical features and consistent CSF profile, empiric anti-tuberculous therapy is justified. And this is reiterated by the British Infection Society guidelines, which states exactly the same. Okay. However, in the CSF, please remember there are some variations in the CSF cytology. The initial polymorphonuclear response may be seen in about 20 to 25% of the patients. And this polymorphonuclear response may be persistent, usually in HIV positive patients. And in those cases, the prognosis is good. In some patients, a lymphocytic response may convert to a polymorphonuclear response during the course of treatment. It is known as a paradoxical response. And again, in these patients, please be careful. Lastly, in HIV positive patients, 16%, and HIV negative 3 to 6%, the CSF may initially show an acellular response. So you can see the difficulties that you face when you are doing a CSF and clinical features. The gold standard is the demonstration of AFB as shown in this slide here. Now, this was in one of my HIV positive patients. You can see that you can see them so distinctly. In the HIV negative patients, we hardly ever see Ziel-Nielsen stain positive. Ziel-Nielsen stain of the CSF is the most important and widely available. It has been there for over 100 years. Unfortunately, it is relatively insensitive and varies from 10% in some centers in India to 86% by Kennedy and Fallon in JAMA. I must clarify that Kennedy and Fallon reported this paper. They were working in the Walter Reed Hospital, which is the hospital in Washington for the armed forces. And those soldiers cannot refuse a lumbar puncture. And therefore, Kennedy and Fallon did 4 CSF samples and achieved a positivity rate of 86%. Nobody has been able to match that, except one lady from UK. She's gone up to 90%. But what did they do? Thwaites and all said that if you collect a large volume of CSF, say 10 ml, centrifuge it for 20 minutes, and then do detailed microscopic evaluation for half an hour, you can jack up your yield to about 58%. Culture of CSF similarly is insensitive. Thwaites and all have managed 71%. Kennedy and Fallon have matched 83%. But if you get a positive, then you can have drug sensitivity testing. There are delay in the results. In solid media, the culture takes about 4 to 8 weeks, and no physician can wait for that period of time to start therapy. The Bactec culture's broth, which is a liquid culture, will take 7 to 10 days. Even that, although it has shortened the period, you cannot afford to wait that long. And therefore, I would like to reiterate practice guideline. If you have a consistent clinical features and consistent CSF profile, empiric anti-tuberculous therapy is justified. Now, other tests are there. ADA, I never believed in ADA. Then Robert Teo and whatnot had found tuberculous stearic acid, expensive, even not. Then there was a time when mycobacterial antigen antibody reaction was thought he had a poor sensitivity, and it got a negative recommendation by the WHO. And here you can see it in Lancet. This was in the year 2011. And there was a report in the newspapers also of the World Tuberculosis Day. Okay. Now we come to the modern investigations. Nucleic acid amplification by polymerase chain reaction methods. A meta-analysis of the commercial NME was published in Lancet Infectious Disease, and it had a sensitivity of 56 and a specificity of 98. Therefore, it was useful, if positive, to rule in TB meningitis. But if it was negative, it could not rule out TB meningitis. Real-time PCR is more accurate and reproducible, an enhanced sensitivity of 86%. And nowadays, it is the preferred PCR technique. The disadvantages are that it's available in tertiary centers, expensive, it requires special laboratory expertise, vigorous quality control, impractical in developing countries. Now, I remember the microbiologist, get her name, she mentioned that if you don't have vigorous quality control and if you reproduce with the polymerase chain reaction, the tubercle fragments are floating in the air and they can settle down on the next lot and produce false positive. So you require vigorous control. However, all that is now in the past with the gene expert. It is a fully automated nucleic acid amplification test. And the WHO in 2013 initially diagnostic tests for TBM, particularly in smear negative. Advantage is that it is rapid. The results are available in 2 hours, but we never get them in 2 hours. It recognizes, that is the main advantage, rifampicin resistance. And therefore, this will give an opportunity to the physician to start secondary line of therapy and reduce multi-drug resistant TB mortality. It is easily learned. It can be used in peripheral centers, and the automated cartridges avoid contamination. The sensitivity in 2 studies done in the UK and Vietnam was 55 to 59%. In India, in 3 centers, to the best of my knowledge, it was 23 to 29%. But I believe the sensitivity has improved from the data coming out from PD Hinduja Hospital. But it is nowhere near a big deal. The specificity, almost 100%. Therefore, the conclusion is the same as RT-PCR. If the gene expert is positive, it confirms TB meningitis. But if it is negative, it cannot rule out TB meningitis. The postgraduate students must be aware of this. If they keep saying, sir, the gene expert is negative, therefore it's not TB, wrong. It can still be TBM because the sensitivity is not very high. Then there is this gene expert ultra, which increases the sensitivity by about 10%. But there are very few centers which utilize gene expert ultra. Then you have this next generation sequencing and pyro sequencing, which rapidly identifies the genome of the organism. There is a multiplex biofire film assay for meningitis and encephalitis, which identifies 14 organisms. But unfortunately, in India, they do not have commercially available, do not identify Mycobacterium tuberculosis. Currently, there are only 2 labs in India which do next generation sequencing and pyro sequencing under the revised National TB Control Program. I think one is in Lucknow and one is in Delhi. Now, coming to the neuroimaging. The neuroimaging techniques are not diagnostic, but they are standard for the complications of TBM. What are the direct signs of TBM? On neuroimaging, basal exudates with contrast enhancement and tuberculomas. And the signs of complications are infarcts with arthritis, hydrocephalus, and cerebral atrophy. This is a patient who came to my attention after March 1997. He was earlier treated in a tertiary hospital under physicians. And look at all the changes of TBM that you see in one patient. Initially, there is meningeal enhancement. The ventricles are normal in size, and you can see here, you can see it here, all meningeal enhancement. In a few months' time, you see that he has, and if you look very closely here, in this area there is early infarct on the CT scan. If they had done an MRI, it would have shown up in the MRI. Then, within a few months, he develops a hydrocephalus, dilated third ventricle, dilated aqueduct, temporal horns, and periventricular ooze. And in March 1990, he had developed a cerebral abscess, massive hydrocephalus, and a mature infarct. He was treated. Dr. Gajendra Singh helped me in evacuating the tuberculous abscess. He put in a shunt and we increased the drug treatment, and the patient slowly recovered. He had a hemiplegia, right-sided hemiplegia, but rehabilitated himself, and I think he runs a telephone stall somewhere near Siddhivinayak temple. Now, this is a rather unfortunate Heiss in Neuroradiology 1992 described an area of the brain which they call the TB zone of infarct, which is centered around the basal ganglia. And this is a patient of mine in 2005. You can see he presented with bilateral caudate nucleus infarcts, right thalamic infarct, hydrocephalus, dilated ventricle. And everything from beginning to end, he died within 11 days of his illness. He had vasculitis with basal, caudate ventricular, and right thalamic infarcts. And I will tell you, I treated him with dexamethasone, but he just didn't respond. And when I talk about corticosteroids, I will give you an idea of why some patients do not respond to steroid therapy. Now, the MRI has a better resolution, not only for infarcts, but also for tuberculomas in the posterior fossa, as you can see here. And you can see with post-gadolinium, you can see the basal enhancement, and you can see the multiple, even tiny tuberculomas, which are not evident on the FLAIR or the T2 weighted images. Now, this is a comparison of the radiology between HIV negative and HIV positive patients. This is a patient who's HIV negative and in stage 2, and you can see the thick basal exudates. And this is a HIV positive patient in stage 3 tubercle meningitis, and you can see hardly any exudates, hardly any. And the other difference is that they have infarcts not in the tuberculous meningitis infarct zone. They have it there, but also over the cortex, because secondary to arthritis. So this is a cortical infarct in a patient who's HIV positive. Now, the angiography has a particular triad. They have a sweeping pericallosal artery, narrowing of the supraclinoid ICA, M1 segment of the MCA, narrowed or occluded medium and small intracranial arteries. However, in India, Dr. Dalal felt that the clinical angiographic correlation was rather poor, and normal angiograms were seen in 42 to 57% of patients with clinical or MRI evidence of infarct. Angiography is therefore not necessary in every case of TB meningitis. Now, just for the postgraduate students, I'd say this is a high sweeping pericallosal artery, suggestive that the ventricles are dilated, the frontal horns are dilated, and therefore hydrocephalus. Here you see a narrowing of the terminal portion, cavernous portion of the intracerebral internal carotid artery. And here you see the same narrowing. And here, more importantly, you see the lenticulostriate vessels, but you can't see the lenticulothalamic vessels. They are obliterated. This is the reason why this part of the middle cerebral artery gets involved in the basal exudates, and it occludes the opening of these vessels. And therefore, the infarcts are essentially in the basal ganglia. Therefore, in TB meningitis, aphasias, apraxias, agnosias are not common findings in infarcts. Now, this is one of my cases with HIV, and the arrow points to areas of narrowing with post-stenotic dilatation, areas of narrowing with a pre-stenotic dilatation. And here you can see another area which was dilated, and the vessel is very hardly seen. This is arthritis of the middle cerebral artery in these patients who are HIV positive. Now, this is a pathology specimen. You can see that the basal exudates are plentiful here. And this is a case of HIV positive. And there is hardly any. There's hardly any basal exudates. And in the pathology, under the microscope, I'll show you, explain to you, this is the surface of the brain. And these are the meninges in a HIV negative individual. And you can see a giant cell Langerhans arteries within the meninges. And you can see the very thick meningeal reaction. In contrast to that, this is a HIV positive, And this is a sulcus. And you can see the very flimsy meningeal reaction that is there in these HIV positive individuals. No wonder they hardly have any basal exudates. And lastly, this is part of the brain where you see occluded blood vessels and rarefication around them, suggestive of arthritis with tiny infarcts, another arthritis and another infarcted area, third arthritis. And when we stain the brains with a Zeal-Nielsen stain, the brain was teeming with air in these HIV negative, HIV positive individuals. Look at, you never see this in an HIV negative individual. Now coming to therapy for TBM. Anti-TB therapy has been around for 60 years. Yet, even today, the optimal composition, the appropriate dosage and duration has yet to be determined. The first line drugs are INH, rifampicin, ethambutol, PZA, and streptomycin. Unfortunately, two of these drugs, rifampicin and ethambutol, hardly cross the blood-brain barrier. And when I'm treating tuberculous meningitis, I hardly ever use ethambutol because it has more side effects, particularly that of optic atrophy, rather than effect. The second line drugs are ethionamide, cycloserine, PAS, aminoglycosides, which are injectable, and quinolones. The global treatment guidelines mention there's an initiation phase of 2 months with 4 drugs and a continuation phase of 9 to 12 months with 2 drugs. Now, this implies that the diagnosis is made early and there is an early initiation of therapy. If that is so in your case, please follow these guidelines. However, in India, from the periphery to the tertiary centers, the diagnosis is delayed by months. And therefore, initiation of therapy is also delayed. And therefore, the duration of therapy varies from 18 months, sometimes to 2 years, 3 years. And I have even treated a female patients with multiple tuberculomas for a period of 4 years. Now, in 2019, Dr. Khadilkar and his colleagues, Rahul Kulkarni and others, did a survey of over 114 responders. They sent out the papers to questionnaire to all the neurologists, but there were 114 responders. And almost all the responders preferred 18 months or longer a period of therapy. I think they very catchily named the paper Guidelines versus Ground Lines. And in the grassroots, people prefer 18 months or longer. Now, role of corticosteroids. There's no question about the role of corticosteroids. Thwaite et al. In 2007 gave dexamethasone and it reduced infarction at 60 days. And dexamethasone affects outcome by resolution of hydrocephalus and preventing infarcts. Critchley and her colleagues did a meta-analysis of 41 trials, and they came to the conclusion that steroid reduces mortality by 17%, but that was in all forms of tuberculosis, including pulmonary, renal, and neurological. Okay. Now, recently, I think Kameshwar Prasad, Mamta Singh, and Ryan have been doing they did it in, I think, 2006, and they revised it in 2016. a Cochrane database review, and they came to the conclusion that steroid reduces swelling of the meninges and blood vessels. It reduces intracranial pressure and the risk of death. However, the effect on disabling residual neurological deficit, and they don't mention the cause of that, whether it is meningeal or due to infarcts, it remains uncertain. Yet they mention about blood vessels. So it leaves a little inconclusive things about steroids. But nevertheless, it is a standard of care to give steroids in the first 6 weeks of tuberculous meningitis. Now, as I mentioned, I was always intrigued by that boy's case. Why did he not respond to steroids? I gave him dexamethasone. Why did he not respond? The answer came practically in 2012 and 17, where Tobin and all worked on polymorphism in the gene encoding for leukotriene A for hydrolase, which is an inflammatory, anti-inflammatory ecosonide. Now, the gene determines the balance between pro and anti-inflammatory ecosonides. Homozygosity, TT genotype, is associated with a high pro-inflammatory cytokines. And therefore, dexamethasone in those cases will be helpful for survival. Homozygosity with a CC subtypes, intermediate or low effect of dexamethasone. Indifferent or dexamethasone can even be harmful in such cases. If you get heterozygosity, C-type, there is a low mortality rates and dexamethasone is helpful. Therefore, I wonder whether my patient who died of vasculitis had a CC genotype for LTA for hydroxylase. So there is a lot to be learned from the literature about the role of steroids in tubercle meningitis. Lastly, I come up to 3 involving clinical entities. Very limited clinical experience and no clear guidelines for the diagnosis and therapy. The first is MDR TBM. I've used the word TBM, but all this data is essentially on pulmonary MDR TB. The definition is resistance to INH and rifampicin. The estimates are there were 558,000 MDR cases in 2017. And the frightening thing is 50% of the global burden is in India, China, and Russia. MDR TB characterized by case reports and small case series. There are no large series in which we can conduct clinical trials. The reason is that there is a delay in identifying resistance. Now, with the advent of gene expert, we hope that delay is reduced. But so far, they come in advanced stages of the disease. And most of this data is on pulmonary TB. There's delay in initiation of appropriate therapy. And therefore, the mortality is very high. Now, let me give you an example of one of my patients. Now, this is MDR TB CNS involvement. Look at the CT scan of August 2020. He had multiple tuberculosis. He was treated elsewhere with anti-tuberculous treatment. They did not go on to secondary line of drugs. And in February 2002, nearly 1.5 years later, he came to us with gross dementia. And look at the amount of tuberculosis. He perished in spite of our treatment It's for MDR tuberculosis. He perished within about 2 months, which is very sad. So consider MDR TBM or even MDR tuberculosis, just TB. If there's a history of prior TB therapy, if the person is in contact with MDR TB case, or there's a poor clinical response to first-line drugs within the first 2 weeks, don't wait longer. Largely, the therapy is based on experience in pulmonary tuberculosis. The first-line drugs plus ethionamide plus cycloserine. And at times, we have given 5 to 7 drug therapy. It becomes horribly expensive. And even patients who are affluent complain about the cost because on a long-term basis, the costs are very high. If the cost of IVIG is about 2 lakhs, they can afford it for a period of 5 days. But if it comes to several thousand a month, about 40,000 a month, and it has to go on for 2 years, even affluent patients complain. Therefore, patients who are in the low income or in the poor, underprivileged, I think they can only afford therapy from tertiary medical centers belonging to the government. The second entity is tuberculous CNS iris. CNS involvement in iris is the most severe form of TB iris and carries a mortality of 13 to 75% depending on the centers. Most of this data is from South Africa. It may be due to unmasking of a subclinical infection of tubercle or a paradoxical deterioration after initiation of ART, which is the more common situation. The risk factors from tubercle site is dissemination of TB. You have pulmonary, lymph, and TBM. You have a disseminated tuberculosis. Or there is raised CSF polymorphonuclear count of more than 50 cells per microliter. Or there is a high CSF baseline Mycobacterium tubercular load. Now, how do you get a high CSF baseline? That the cultures are usually positive. The cultures are negative because it is a paucibacillary. But if the CSF baseline load is very high, the cultures are likely to be positive. So if you have disseminated TB, raised CSF polymorphonuclear count, or a culture positive TB, CSF culture positive TB. Then from the HIV side, if you have a low baseline CD4 count, you have a high viral load, you have a sudden increase in the CD4 count, and a greater than 2 log drop in the viral load. Please be careful. This can result. And see, this was the case I will show you. On the top 2 slides, you can see that there was a tuberculoma in the right frontal area. In May 2003, he was treated by an infectious disease expert and he was given adequate anti-tuberculous therapy, but within 1 month, he was started on heart. Okay. He presented to me thereafter, a few months thereafter, in July. And I somehow advised him to continue with the treatment. So he presented in August with a deteriorating level of consciousness. And look at the massive increase in the tuberculosis with clinical deterioration. He was admitted in Jaslo. And at that stage, I presented the case to a person called Bruce Brew, who is an expert on HIV and nervous system. And I asked him whether he thought that this was TB iris. and he felt that it was TB iris. And that stage, there was no clear guidelines. So what we did was we stopped we continued anti-tuberculous therapy, gave him steroids, but I stopped the heart. And I was lucky because by November 2003, you can see the results. I kept him only on PCP prophylaxis. Subsequently, he was lost to follow-up. But the modern guidelines I have published in Ambar Chakravarti's book on neurology and internal medicine case report basis. I've reported this case there and reviewed the literature there on what should be the therapy. Nowadays, the therapy should be you can continue heart. Usually this develops if heart is started within 2 months of therapy. Now, therefore, the dilemma is, should we delay initiating heart? Therefore, should we avoid opportunistic infections in India, which are more common, or run the risk of developing iris? The second question was stopping heart during iris. And nowadays, it is not necessary to stop heart. And lastly is the use of systemic corticosteroids justified. I was lucky, but there's a lot of literature which states that it may suppress immunity and produce more opportunistic infections. The last, and this is my last slide, the definition of XDR or extreme drug resistant tuberculosis. The definition is MDR resistant to any of the fluoroquinolines and any of the secondary injectable drugs. It was first reported in 2006. Now, between 2006 and 2012, 92 countries have reported at least one case of XDR TB, essentially pulmonary. 13 countries have reported more than 10 cases of XDR TB. And this is from the WHO Global Tuberculosis Control Report 2021. Most of the cases are pulmonary. Therefore, we have no idea of what XDR TB would do if the central nervous system is involved. Okay, most cases are pulmonary, and MDR converts to XDR at a rate of 9.6% due to mismanagement of MDR by use of drugs which are more toxic and less potent. And therefore, in this regard, I would like to draw your attention to this paper which has come out in the New England Journal of Medicine on 1st of September 2022. Please remember, it's only 4 days old. Okay, where they are using 3 drugs: bedaquiline, pritomanid, and linezolid. And bedaquiline is given as 200 milligrams daily for 8 weeks, and then 100 milligrams daily for 18 weeks. Pritomanid, 200 milligrams daily for 26 weeks. Regarding linezolid, they tried out 600 milligrams for 26 weeks or 9 weeks. They tried out 1200 milligrams for 26 weeks or 9 weeks. And they found out that linezolid at 600 milligrams for 26 weeks was the ideal dose, where the side effects were less and the beneficial effects were much more. And they had 181 participants in this trial, out of which 88% were XDR or pre-XDR cases. That means MDR going into XDR. And what was the results? 84 to 93% good outcome. So I think this is a very important study. More work needs to be done on them. And it's only 26 weeks. So about 6 months, a little over 6 months. All right. So that is as much as I would like to talk on CNS tuberculosis. Thank you for your patience.
Absolutely brilliant. The 1st of September article was 4 days old. It is there. It's fortunately free. Any day is giving us free.
Oh, it just seems that I was reading about it.
Yeah, I just saw it on the net. And it's free. Fortunate.
Yeah, it's free.
Yeah, it's free. So,
But if you get this thing called medical dialogues,
yeah,
you get something called medical dialogues.
correct.
On the 2nd of September in medical dialogues, there is an extremely good summary of this paper reviewed in medical dialogues. You know, and it has shown a very nice table of the 4 doses of linezolid and all the side effects. The adverse effects, optic neuritis. Optic neuritis occurs, but it is totally reversible. So,
Rakesh, yeah.
Excellent, sir. I mean, thoroughly enjoyed. I think each and every word of your slide was so clinically relevant and important. Sir, I wanted to ask you, there is a data which shows that aspirin in the treatment of vasculitic infarcts of TBM.
yeah,
Yes, sir.
it was first proposed by our UK Mishra, you
Yes,
know,
sir.
and subsequently there has been a trial from South Africa.
Yeah.
They have found it useful. But you see, it is given in addition to steroids and in addition to anti-tuberculous therapy.
Yes, sir. Yes, sir.
But they have not given anti-tuberculous therapy plus steroids plus aspirin to one group and without aspirin to another group. So I think in my paper that I have reviewed, I have made a mention of it. If one does not know whether the beneficial effect is due to aspirin, the anti-platelet drug, or aspirin as an anti-inflammatory drug.
Okay.
Yes, sir.
You know,
Yes, absolutely.
but since aspirin is relatively harmless, relatively, and we have a lot of experience of using aspirin in TIs, there's no harm in giving aspirin.
Perfect,
Okay.
sir.
But
Yes.
you are giving aspirin after the horse has bolted. You're trying to close the door.
Yeah.
Therefore, should you give aspirin to each and every patient of tubercle meningitis?
Hmm.
Now, steroids are the standard of care in the first 6 weeks.
Yes, sir.
Should you add should you add aspirin in the first 6 weeks as the standard of care? Now that is open for discussion because there's not enough
True, sir. True, sir.
data.
So this thing you pointed out, this, that some people have this thing, genetic polymorphism,
Yeah,
where the dexamethasone may not work, as in that patient of yours. Is it?
yeah, CC.
Yes.
uh,
that,
Homozygous CC genotype.
yeah. Is that available, sir? Can we test it?
No. I wrote to Kubin. It's not even accepted in Scotland,
Acha.
where he has done the work.
Uh-huh.
Basically. I mean, this is a theoretical possibility.
Right.
And even if you start doing all those genomic workups,
Yes.
it's going to take time.
Yeah. Yeah. Yeah.
But I was only intrigued by this boy's case. In spite of giving him dexamethasone, 4
Correct.
milligrams 8 hourly, he just
Yeah.
went on deteriorating and
Quite
died.
right.
You know,
Quite
therefore,
right.
some patients don't respond to steroids.
Quite right. So excellent. Excellent.
I think we're going to the next part of our morning session. We're going to take 5 topics on infection. Dr. Amna is going to talk about neurological infection. Dr. Chandrasekhar is going to talk about meningitis. Atish is going to talk about encephalitis and brain abscess. Darshan is going to talk about peripheral nervous system. And the toughest topic is taken by Dr. Yash Jain. He's going to talk about infections in patients on immunomodulatory and immunosuppressive therapy. So let's start with Dr. Amna Mania. She's worked very hard. She has brought out some very interesting aspects more relevant to the Indian neurologist. Dr. Amna, yeah, started sharing the screen. Excellent. Yeah. Thank you so much. Yeah. Please start, Amna.
Respected teachers, a very good morning to all of you. Our today's continuing discussion is on neurological infections, and I'll be talking about the first topic on the approach to neurological infections. Starting with introduction, neurological infections can affect any level of the neuraxis. Infection must be considered in the differential diagnosis of any neurological presentation, like meningitis, encephalitis, focal multifocal brain lesions in case of cranial neuropathy, myelopathy, radiculopathies, neuropathy, neuromuscular junction disorders, and myopathy. These infections, they can be caused by any category of microorganisms like bacteria, viruses, fungi, or parasites. These infectious agents, they can affect the nervous system by directly invading the neural tissue by producing neurotoxins or by producing an immune response. Certain pathogens, they cause a specific clinical syndrome and neurological presentation, but many of them, they cause a variety of presentations, and many pathogens cause the same presentation. So as neurologists, we have to be familiar when to consider an infectious cause, how to make a precise microbiological diagnosis so that we can start empirical treatment for the patients as soon as possible. So in this aspect, I'll be discussing about the approach to neurological infections. In clinical approach, I'll be mainly talking about the time course, the associated signs and symptoms, the context, and how to do syndrome identification and localization. In time course, most of the viral bacterial infections, they present acutely, and in majority of the fungal, mycobacterial, spirochetal, and parasitic infections present subacutely. However, there are exceptions to this, like PML caused by JC virus can present subacutely, HTLV1 associated myelopathy, which causes tropical spastic paraparesis, and that has a very slowly progressive chronic presentation. HIV associated neuropathy, neurocognitive disorders, and myelopathy also presents chronically. In fungal, mycobacterial, and neurosyphilis, it can have an acute presentation when they present with stroke and seizures. And there are certain parasitic infections also that can have an acute presentation, like neurocysticercosis presenting with seizures and schistosomiasis causing acute myelopathy. Next, looking into the associated signs and symptoms, there are certain skin changes seen in certain infections that help us in clinching the diagnosis. Like particular purpural rashes are seen in meningococcal meningitis, a dermatomal vesicular rash is seen in zoster infections, target-shaped lesions, which are characteristically known as erythema migrans, are seen in patients with Lyme's disease. Many times in confusing cases, it helps us in making our diagnosis. And as we all know, hypopigmented patches are seen in patients with leprosy. There are certain ocular findings which are seen in certain neuroinfections, like pupillary light near dissociation known as agile Robertson pupils is seen in patients with syphilis. Chorioretinitis is seen in CMV infections, macula star in Bartonella Hensley chorioretinitis. Patients with malaria have retinopathy. Subconjunctival and subretinal cysts are seen in neurocysticercosis, and choroid tubercles are seen in tuberculosis. Coming to other system involvements, pulmonary involvement is commonly seen in endemic mycosis and in pulmonary tuberculosis associated with CNS TB. And cardiac involvement is seen in Chagas disease in the form of heart failure. And if brain abscess, mycotic aneurysms, or meningitis result from endocarditis, that will be associated with cardiac involvement. An example for this is Austrian syndrome, in which patient presents with a triad of pneumonia, endocarditis, and meningitis caused by Streptococcus pneumonia. GI involvement in the form of nausea, vomiting, abdominal cramps is commonly seen in botulism, and colitis can occur along with CMV, encephalitis, and radiculitis. Genital lesions are commonly seen in syphilis and HSV-2 infection, and these can cause meningitis, encephalitis, and lumbosacral radiculitis, which is commonly known as Ellsberg syndrome. Orchitis is seen in patients with mumps, flaviviruses, lymphocytic choriomeningitis virus, and brucellosis, which can further cause neurological infections. Next, coming to the context, there is a high suspicion of neurological infections in immunocompromised patients because of HIV, or patients with some hematological malignancies, or taking some immunocompromised medications. In HIV patients, the CD4 count helps us to determine the predisposition to certain neurological infections. Like cryptococcal meningitis and PML is commonly seen with counts below 200. Toxoplasmosis and primary CNS lymphomas are common with CD4 of less than 100. And CMV infections like retinitis, encephalitis are seen with counts of less than 50. The patient gives a previous history of head injury. We can make a suspicion of CSF leak, which predisposes to meningitis. And patients who have undergone recent neurosurgery, they have a high risk of hospital-acquired meningitis and subdural empyemals. Coming to travel history, in today's scenario, because of increasing travel and migration, patients are commonly presenting in non-endemic regions with infections which are acquired elsewhere. So if we are aware of certain infections which are common in certain regions, it will help us in making diagnosis for patients presenting with certain infections. Like Lyme's disease, it is endemic in northeastern, mid-Atlantic, US, and Europe. It is uncommon in India, but it is commonly reported from the rural areas of Haryana. Similarly, histoplasmosis is endemic in Central and South America, Southeast Asia. In India, it is common in Delhi, UP, Haryana states. Neurocysticercosis is common worldwide. Infections like leprosy, malaria, TB, tetanus, they are very common worldwide, particularly in India. In those, leprosy and TB are commonly seen in the congested city areas, and malaria is common in the central and eastern regions like Orissa, West Bengal, Jharkhand, Chhattisgarh. Japanese encephalitis, as we know, is commonly reported in the eastern UP cities like Gorakhpur and also around the Kesanur forest areas of Karnataka. Chikungunya is very common in Maharashtra, Karnataka, and Andhra Pradesh, and dengue is common in northern states like Delhi, Haryana, and Chandigarh. Coming to exposures, certain exposures are commonly associated with certain infections, like exposure to cats causes toxoplasmosis and Bartonella infections. Pig exposure, as we all know, causes neurocysticercosis. Consumption of unpasteurized milk is associated with Brucella and Listeria infections. Home canned foods can cause botulism. And people who are involved in hiking and outdoor activities commonly present with Lyme's disease and arboviral infections. Freshwater swimming causes schistosomiasis, and drug abusers with subcutaneous injections have risk of developing wound botulism. Next, I'll be talking about localization. First, starting with meningitis, it is the inflammation of the meninges, but the brain is also involved. It is meningoencephalitis. Chronic meningitis is considered when the symptoms are for more than 4 weeks. Recurrent episodes of meningitis are commonly seen with HSV-2 infection. As I mentioned earlier, acute meningitis is commonly seen with bacterial, viral, and parasitic infections, and chronic meningitis is common with fungal infections and some bacteria like Mycobacterium tuberculosis and meningovascular syphilis. In bacteria, neonates are commonly prone to Listeria, E. coli, and B streptococcal infections. In adults, as we know, pneumococcal and meningococcal infections are most common. In immunocompromised individuals, Listeria is common. Patients who have undergone VP shunting are prone to Staph aureus and epidermidis infections. In nosocomial, Staph aureus and Pseudomonas infections are common. And these are the common viruses and parasites, fungi causing meningitis. Acute bacterial meningitis is a neurological emergency, so we have to start empirical treatment. In community-acquired meningitis, Coverage is given with third generation cephalosporins, most commonly ceftriaxone. And vancomycin is added to cover the resistant Streptococcus pneumoniae species. In suspected Listeria infections, ampicillin is added. For nosocomial infections, vancomycin is given and coverage is given with Pseudomonas in the form of cefepime, ceftazidime, or meropenem. If meningoencephalitis is a concern, empirical ampicillin is added. IV steroids in the form of dexamethasone should be initiated because it helps us in reducing the mortality. It decreases the risk of hearing loss in children with H. influenza meningitis. However, there are several studies which are showing that steroids are of not of use, particularly in meningitis in low-income countries. But those studies are stating that in low-income countries, patients they have a late presentation, they have a high burden of HIV and malnutrition. So that is why steroids might not be helping in those places. Next, coming to encephalitis is the inflammation of the brain parenchyma. Most commonly from viral infections, it occurs. In viruses, the most common is herpes, HSV1. Also, enteroviruses and arboviruses can cause encephalitis. And in immunocompromised individuals, CMV, Epstein-Barr virus, and adenoviruses are prone for encephalitis. Acyclovir is started empirically for these patients. A definite etiology for encephalitis is not determined in more than half of the patients who present with an encephalitis picture. Now, the cited studies which have been done in these patients, they preceded the characterization of many autoimmune causes of encephalitis. So, if any patient, when there is an infectious etiology is not discovered, an autoimmune encephalitis should be considered and appropriate antibody testing should be obtained in those patients. Next, talking about focal or multifocal brain lesions, they can result from various etiologies, but in infections, the common etiologies are bacterial and fungal abscess, toxoplasma, tuberculosis, cryptococcus, neurocysticercosis, and granulomatous amoebic encephalitis. Many times, multifocal infections, they can be confused with some cardioembolism, hypercoagulable state, and primary serous vasculitis. Coming to cranial neuropathies, cranial neuropathies have various etiologies. In infectious etiology, it can either complicate meningitis or it can occur in circulation. A common example of an infectious cause of cranial neuropathy is the element 7 cranial nerve palsy caused by Lyme's disease and HIV infection. In myelopathies, spinal infections, infection can occur in any compartment. It can affect the vertebrae and discs, causing osteomyelitis. Infections can occur in the epidural spaces and also in the spinal cord parenchyma. Some important features that help us to identify that it is an infectious cause for myelitis is that patients associated present with fever, pain, and there's localized tenderness also in these patients. Acute myelitis, it can be caused by any virus. A peculiar anterior horn cell involvement that causes flaccid paralysis is seen with enterovirus, polio, and West Nile viruses. As I mentioned before, acute subacute myelitis is caused by schistosomiasis, and chronic myelitis is seen with HTLV1, HIV, and syphilis. The unique syndrome of tetanus is because of the effect of the toxin on the spinal inhibitory interneurons that causes the diffuse tetanus spasms. Next, coming to radiculopathy, these patients, they present with sensory motor deficits in the involved dermatomes along with the radicular pain. In most of the cases, radiculopathy is because of structural cause, but there can be infectious causes also. Like the common infectious causes are viral, the form of varicella zoster and HSV2 infection. In immunocompromised patients, we commonly see CMV infections in which patients present with painful radiculitis, and Lyme's disease and TB can also cause radiculopathy. Peripheral neuropathy, it is broadly classified into mononeuropathy, mononeuritis multiplex, and polyneuropathy. Infectious causes for mononeuritis multiplex are hepatitis B, hepatitis C associated vasculitic neuropathy, where patients present with painful neuropathies, and HIV and leprosy. Now, infections associated with polyneuropathy are seen in HIV and in diphtheria. Coming to NMJ disorders, as we all know, most commonly immune-mediated disorders affect the NMJ, like myasthenia gravis and Lambert-Eaton syndrome. An infective cause of neuromuscular junction disorder is botulism. It causes an acute descending paralysis that affects the oculomotor and the bulbar cranial nerves, followed by involvement of the extremities. In myopathy, infectious cause of infectious myositis can be focal, as seen in bacterial pyomyositis, or diffuse, seen in trichinosis, HIV, and HTLV1 infections. I'll be talking about diagnosis, first about neuroimaging. Here I'll be mentioning about the common neurological infections in which neuroimaging helps us in making the diagnosis, and also some specific neurological infections which have some peculiar radiological pattern which helps us in making the diagnosis. So first, starting with neurocysticercosis. In this, the CT image, as we can see on the left side, where there's a hypodense lesion seen behind the occipital horn of the lateral ventricle on the right side, which is indicating neurocysticercosis in the colloidal vascular stage. And in the right side, the multiple punctate calcifications are seen, which is indicating the calcified nodular stage of neurocysticercosis. In TB, as Sir has already mentioned, basal cistern hyperdensities and basal meningeal enhancement is seen, and associated complications also can be seen in tuberculosis like hydrocephalus and infarctions. These diagrams are showing, upper diagram is showing an infarct in the left basal ganglia, and followed by hydrocephalus, and the basal and leptomeningeal enhancement seen in tubercular meningitis is seen in these diagrams. Next, I'll be talking about PML. It has a characteristic propensity for involvement of the juxtacortical white matter and the middle cerebellar peduncle. Here, hypodensities are seen bilaterally. Here, bilateral frontal white matter hyperintensities are seen. And here, there's involvement of there's T2 hyperintensity in the left MCP. In HSV, T2 hyperintensities are seen in the limbic cortical regions, as seen in this diagram. There's involvement of the medial, inferior, temporal, insular, inferior frontal, and orbitofrontal regions. This can be associated with the hemorrhage, contrast enhancement, and/or diffusion restriction. Coming to some peculiar presentations, schistosomiasis gives a characteristic arborized pattern of contrast enhancement. Arbovirus encephalitis, it causes T2 hyperintensities in the basal ganglia and thalamus. And autoimmune encephalitis, it causes T2 hyperintensities in medial temporal lobes. This is just an overview of the radiological features of the common infections. As I've already mentioned about the common limbic region involvement in herpes simplex, PML involvement, and the ring enhancing lesions commonly in tuberculosis, neurocysticercosis. In immunocompromised individuals, we see in toxoplasmosis and primary CNS lymphomas also. Next, about coming to CSF analysis, it really helps us in making a definite diagnosis of the causative microbe, and we always start empirical treatment for the patients. But the cellular and biochemical changes, they last in the CSF for up to 2 to 3 days, even after starting the antibiotics. So it still CSF is useful in making our diagnosis. In infections, there is rise in the WBC count and the proteins. Bacteria infections, they show neutrophil predominance, and viral fungal infections, they show a lymphocyte predominance. However, a neutrophil predominance is seen in the early stages of viral infection, so we should remember that. And glucose levels are decreased in bacterial fungal infections, and they are normal in most of the viral infections. However, they can be decreased in some viral infections like mumps, HSV2, and CMV infections. CSF eosinophilia is classically seen in parasitic infections, and they can be seen in some fungal infections like coccidioidomycosis. Coming to the microbiological diagnosis, first microscopy and staining, it helps us in case of gram staining, helps us in bacterial infections. Acid-fast staining is very useful for mycobacterium tuberculosis, mycobacterial infections, and India ink stain, it helps us for diagnosing fungal infections like cryptococcus. Coming to cultures, CSF culture is the test of choice for bacterial infections, but it is insensitive for virus, spirochetes, and fungi. TB culture is also sensitive, but as we all know, it takes such a long time for the organism to grow. So we need some other investigations that will help us in making the diagnosis. So latex agglutination and immunoassays are being used, where specific antibodies are used to detect the microbial antigens or toxins. An example for this is the CSF cryptococcal antigen testing, which is the most sensitive test for cryptococcal meningitis. And now, as we all know, PCR technique has become a commonly used technique in which amplification of the microbial genetic material is done, which helps us in easily identifying the organism. And CSF PCR is the test of choice for majority of the viruses. And as we all know, in tuberculosis, also gene expert testing is being used, which helps us in making the diagnosis. It gives an early results, and it also helps us in identifying rifampicin resistance. Serological tests are also available. It refers to measurements of the antibodies which are formed against the infectious agents. There are certain infections in which the CSF serology is more sensitive than PCR testing, as in case of arboviruses, varicella zoster, Lyme's, and neurosyphilis. This is just an overview of the most sensitive test for the specific pathogens. So we should be aware of which pathogen we are suspecting and which will be the best test for those pathogens so that we can make the diagnosis as soon as possible. Now, multiplex PCR tests are available, which can test for different causes simultaneously. As Sir has also mentioned that BioFire is available, which is a very useful test it's a panel for meningitis and encephalitis, which tests for 14 different organisms, 6 bacteria, 7 viruses, 2 fungi. It is very useful, but unfortunately it's expensive, but it can be life-saving for the patients. Now, next generation sequencing is available on the CSF, which is emerging as an unbiased technique, which helps us to evaluate all the genetic material. It identifies them using bioinformatic libraries. And this technique is identifying some pathogens that were not possible to be diagnosed earlier by the conventional testing. So, but this is not very commonly available now, but it is emerging as a very useful test. So to conclude, in my conclusion, I want to say that infections are to be considered in the differential diagnosis of any neurological presentation, and it affects individuals of all age groups. And the classic clinical features may be absent in many of the patients. So we just cannot rely on the clinical presentation of the patients. And also the contextual features like past medical history, travel exposures, they are very important and they help us in providing important clues to the diagnosis. In immunocompromised individuals, we have to think of and we have to have a high index of suspicion for neurological infections. And these patients, they can have an atypical radiological features. So the definite microbiological diagnosis can be made by the different techniques that are now available, as I mentioned already. So as neurologists, we require to be aware of the most sensitive tests for each pathogen, which is to be considered, so that we can make an early diagnosis and start empirical treatment for the patients as soon as possible without wasting any time. Thank you.
I think it's a very good presentation, Amna.
Thank you, sir.
You have covered a lot. I have a few comments. One is we made an honest effort to look at the neuroepidemiology of CNS infections in India. We got a lot of data on an individual basis of PGI Chandigarh from NIMA and Bangalore, but we did not get an Indian overview of CNS infection. So it has been a lot. Whatever the 4 slides she has mentioned about chikungunya, what have you, there's been a lot of hard work in that. One important thing in a Viva, which was common once upon a time for exam-going students, she mentioned about the association of neurocysticercosis and pork eating. And that is true in the Western world, that is true specifically in South America. But in India, you see patients who are complete vegetarians, who have never ever eaten any form of meat ever in their life, coming to you with focal seizures with a ring-enhancing lesion, probably neurocysticercosis. Obviously, we don't have a biopsy diagnosis in all our patients and probably in hardly any patient. So get ready in your Viva to say that if a patient is a complete vegetarian, how has he developed neurocysticercosis? You find out the answer and get ready for that answer. Okay? If you don't know, you can call me up. Right? Anyone else wants to say anything?
I think it was an excellent presentation, very comprehensive, and she really covered the whole spectrum.
Whole spectrum. Whole spectrum.
Yeah.
Thank you, sir.
I like that very much. Thank you so much, Doc.
Thank you, sir.
Shall we go to the next topic? Please start sharing your slides. That's it. Yeah. We are talking on tuberculosis. Chandrasekhar is doing it.
No, sir, meningitis. Sir.
Yeah.
Meningitis, sir.
Acha, Chandrasekhar, can you hear
Yes,
me?
sir. Yes, sir.
Yeah, I think Dr. Katrak has covered so wonderfully the TBM. So
Yes,
I
sir.
think when you come to TBM, you just skip those slides. Okay?
Yes, sir. Yes, sir.
You know, that will be good. Okay.
Good morning, respected teachers. Today I am going to cover meningitis under the guidance of Lal Kaka, sir. So meningitis is an inflammatory condition of the meninges that can be caused by infections, autoimmune diseases, neoplasia, and medications. The infectious causes of meningitis include
Chandrasekhar, your slides are not moving.
not moving, sir.
Ah, okay. Yeah.
So, sir, meningitis is an inflammatory condition of the meninges that can be caused by infections, autoimmune diseases, neoplasia, and medications.
You can
The
put it on
infection,
slideshow, no? You can put it on slideshow.
so it is not coming on the slideshow. So that's why.
Acha, okay.
So infectious causes of meningitis include bacteria, viruses, fungi, and parasites. So bacterial meningitis is the acute purulent infection within the subarachnoid space. The most common organisms will be Streptococcus pneumonia, Neisseria meningitis, Group B Streptococci, Listeria monocytogenes, and Haemophilus influenza. According to the age, the Listeria is more common in neonates above 50 years of age. The Neisseria is seen in between 2 to 20 years, and Streptococcus pneumonia, Neisseria is more common in 18 to 50 years of age. The Staphylococcus aureus and gram-negative is the most common cause of meningitis in post-surgical patients. The Haemophilus will affect the unvaccinated children. The Streptococcus pneumonia is the most common cause of the bacterial meningitis, and the predisposing factors are splenectomy and immunoglobulin defects. Neisseria meningitis will cause purpuric rash, and respiratory transmission is the main mode of transmission. So contacts need antibiotic prophylaxis with rifampicin and ceftriaxone. Eculizumab, usually used in the treatment of myasthenia gravis and neuromyelitis optica, will increase the increased incidence of meningitis. Haemophilus influenza is more common in children between 3 months to 6 years of age. Staphylococcus species and gram-negative organisms are more common in patient with surgery, trauma, IV drug abusers, and CSF leak. Streptococci agalacticae, Group B Streptococci is common in infants exposed during passes to the birth canal. Listeria monocytogenes more common in immunosuppressed patients 65 years above age of 65 years and alcoholic patients. The pathophysiology is the bacteria will enter into the subarachnoid space. There will be a multiplication of the organisms and the lysis of the organisms by the antibiotic and the host humanity, and the release of the bacterial cell wall components like teichoic acid, lipopolysaccharides that will enhance the production of cytokines like tumor necrosis factor alpha, interleukin 1, and chemokines that will increase the intracranial pressure and cause coma. The brain imaging should be done before lumbar puncture if there is a focal sign on neurological examination, coma and raised ICT, papilledema, and new onset of seizures. This is the axial, the first diagram shows axial contrast enhanced T1 weighted image shows no definite meningeal enhancement. The second diagram shows the contrast enhanced flare shows small focus of enhancement related to the right temporal lobe. Then the C diagram is the non-contrast flare, as there is also no definite meningeal enhancement. So contrast enhanced flare sequence is a more accurate sequence than the contrast enhanced T1 weighted sequence in diagnosis of meningitis. So in all suspected cases of meningitis, contrast enhanced flare sequence should be a regular sequence for diagnosis. And this is the axial contrast enhanced T1 weighted MRI showing frontal subdural fluid collection with meningeal enhancement. The similar findings seen in the axial contrast enhanced flare sequence, but these are findings are more obvious, like contrast enhanced, more obvious than the T1 weighted image. The empirical treatment in bacterial meningitis should be initiated immediately. Outcomes are worse with delayed treatment. Treatment is then adjusted based on the CSF culture and antibiotic sensitivity. Dexamethasone should be initiated before or with the first dose of antibiotics. The pattern of reactions in spinal fluid in neurological infections. In bacterial meningitis, the protein will be more than 100 and the glucose will be less than 40% of the serum. The white blood cells are more than 500. The cell type predominance will be neutrophils. In viral meningitis, the proteins will be less than 120 and glucose will be more than 40% of the serum, and the white blood cells will be between 10 to 500, and the cell type predominant will be lymphocytes. In tuberculosis and non-infectious granuloma, the protein will be more than 50 and the glucose will be less than 40% of the serum. White blood cell between 10 to 1000 and lymphocyte predominant. Coming to the treatment of the bacterial meningitis, in all acquired meningitis, vancomycin given at the dose of 15 to 20 milligrams every 8 hours and a daily dose of 60 mg per kg, adjust a dose based on serum drug level until sensitive organisms are known. And ceftriaxone 2 grams IV every 12th hourly or ceftriaxone 2 grams IV every 4 to 6 hourly, and dexamethasone 10 mg IV every 6 hourly for 4 days. In alcoholics or advanced age and immunosuppressive states, considering listeria as a possibility, we should also add ampicillin 2 grams IV every 4th hourly, and who are allergic to penicillin, trimethoprim sulfamethoxazole 10 to 20 mg per kg body weight IV divided every 12th hourly. In neurosurgical procedures like stent infection and head trauma, vancomycin plus anti-pseudomonal beta-lactam such as cefepime or ceftazidime 2 gram IV every 8th hourly, or meropenem 2 gram IV every 8th hourly to cover pseudomonas. In children, ceftriaxone given at the dose of 50 mg per kg every 12th hourly, or cefatoxim 100 mg kg IV every 8th hourly, and vancomycin 15 mg per kg every 6th hourly plus dexamethasone 0.15 mg kg body weight IV every 6th hourly. Coming to the duration of antibiotic therapy, in streptococcal meningitis, the antibiotic duration will be 10 to 14 days. In Neisseria meningitis, it will be 7 days. And Listeria and gram-negative meningitis, antibiotic should be given for 21 days. And group B streptococci antibiotic should be given for 14 to 21 days. Coming to viral meningitis usually causes a rapidly evolving headache, fever, and stiff neck, but the symptoms are less severe when compared to the bacterial meningitis. Most of the viruses are diagnosed by PCR. Some are more sensitively diagnosed by CSF serology, such as arbovirus. So the virus, the best diagnosed by serology will be West Nile, mumps, and La encephalitis virus. Other viruses best diagnosed by PCR will be Herpes simplex type virus, Seaman parvovirus, varicella zoster virus, cytomegalovirus. The herpes simplex virus type 2, HSV1 causes encephalitis, whereas HSV2 commonly causes meningitis. It also causes recurrent meningitis. It will occur as a complication of genital herpes without history of sexual exposure or genital infection. The diagnosis will be made by CSF PCR. The West Nile virus meningitis is a mosquito-transmitted flavivirus. It causes meningitis, encephalitis, and acute flaccid paralysis. And diagnosis is also confirmed by the identification of the anti-West Nile virus IgM in CSF. The mumps virus is the most common cause of viral meningitis prior to the widespread mumps vaccination, diagnosed by CSF IgM serology or PCR. And the varicella zoster virus is the meningitis that occurs with or without concurrent rash. The disseminated infection seen in immunocompromised patient. Stroke may occur due to vasculitis, and the diagnosis by CSF PCR. The neuroimaging in patients with viral meningitis is most commonly normal. It will be performed to rule out encephalitis and bacterial abscess and other causes of meningitis. Coming to the treatment of viral meningitis, HSV2 and varicella zoster meningitis is treated with acyclovir at a dose of 10 mg per kg IV 3 times a day for 10 to 14 days. 14 days course of IV therapy should be recommended for patients, immunocompromised patients. Chronic meningitis, the meningitis that lasting more than 1 month without any improvement. Infections will be TB, Listeria, brucellosis, syphilis, Lyme, and Leptospira. The fungal infections causing chronic meningitis will be cryptococcal coccidiohistoplasma, and the parasite will be Toxoplasma, Tinea, Schistosomiasis. Autoimmune causes like SLE, Sarcoidosis, Wegener. Even malignancy like leukemia, lymphoma, metastatic carcinoma of lung, breast, and prostate. Coming to Treponema pallidum, it causes meningovascular syphilis. It should be considered in patient with HIV or history of other STD diseases. The serum, VDRL, and rapid plasma reagent usually positive, and fluorescent treponema antibody test will be also positive. But the most specific for neurosyphilis is CSF VDRL. If the test is negative, CSF fluorescent treponema antibody test should be performed. Coming to treatment, high dose of penicillin should be given 2 to 4 million units of penicillin G every 4 hours for 10 days. Coming to fungal meningitis, Cryptococcus fungal meningitis is the most common cause. The most patients will be immunocompromised patients, but the Cryptococcus gutti will cause meningitis in immunocompromised patients. Cryptococcal antigen, the most sensitive test, and Indian ink test is insensitive. Coming to treatment, liposomal amphotericin be given 3 to 4 mg per kg per day, plus flucytosine 100 mg kg per day for 2 weeks. Consolidation treatment with fluconazole 400 to 800 mg per day for 8 weeks. The maintenance therapy with fluconazole 200 to 400 mg per day for 1 year. This is the image of cryptococcal meningitis. This is the axial T2 weighted image showing cluster of gelatinous pseudocyst with soap bubble appearance at the periventricular white matter in the basal ganglia and in the middle cerebral midbrain peduncles and dentate nucleus, and also there is a mild gadolinium enhancement on the right caudate nucleus. Coming to the histoplasmosis and blastomycosis, this is endemic in Mississippi. It also both will cause a pulmonary infection along with CNS infections, and blastomycosis will also cause intracranial abscess and epidural abscess. Diagnosis by CSF serology and antigen testing. The treatment will be liposomal amphotericin be given at the doses of 5 mg per kg per day over 4 to 6 weeks, followed by itraconazole 200 mg BD until CSF abnormalities have resolved. Candidiasis. Candidiasis is more common in immunocompromised patients, especially in neutropenic patients. It may result from infection of the ventriculoperitoneal shunt or as a complication of neurosurgery. A diagnosis by CSF culture and CSF13B beta D glucan is frequently positive in patients with candidal meningitis. Coming to treatment, liposomal amphotericin be given 5 mg per kg per day with flucytosine 25 mg per kg by 8 hourly, followed by fluconazole 400 mg to 800 mg per day. The infected ventriculostomy drains and VP shunt should be removed. The take-home message will be infectious meningitis is a neurological emergency. The prompt evaluation and accuracy of diagnosis and early treatment are critical. New PCR-based techniques have improved the timelines of microbiological diagnosis in meningitis. And next generation sequencing of CSF for the diagnosis of infection that is not identified by the convention should be applied. Thank you.
Jimmy?
And concise and very nice, Chandrasekhar.
Thank you,
Just
sir.
one or two things I think we need to also stress on in this meningitis is the vaccines. I think we need to, the pneumococcal vaccine and the meningococcal vaccine.
Yes.
Pneumococcal vaccine, I think, should be given to practically all, healthy people also over the age of 65 years. as well as in people who have splenectomies and other, high risk groups. Meningococcal vaccine should be given more in, I think, in children and people who are, susceptible high risk groups again, like people staying in dormitories and, places where it can spread. And if there is a definite contact with a person with meningococcal meningitis, the chemoprophylaxis with rifampicin is also very, very necessary. So I think this vaccination part and preventive part also we need to keep in mind.
Great.
Ashok?
Yeah, so you take the next topic.
Yeah.
Yeah, hello. Rakesh, you want to say something?
Yeah, just one point.
Yeah.
For this diagnosis, these panels which have come, sometimes they throw up some false actually positive, viruses, or mostly I think viruses, which doesn't gel with the
Yeah.
whole clinical picture.
I've had
I have
that
seen
experience.
two HHV
Quite right.
6. HHV 6 I have seen in 2 patients, and it just did not gel with the whole picture, So I think we have to be
Quite right.
aware of these false
And
positives.
something else, Rakesh, something else also, just the opposite. There was once a patient, I remember, with florid TB meningitis. I mean, you couldn't have, everything fitting in. Clinical profile, CSF, classical, absolutely classical. And we did these tests, and the TB thing came negative.
Okay.
So,
Yes.
I mean, I don't know really how reliable these things are.
Actually, sir, these are
Either false positive or false negative.
actually, I was asking this
Sorry?
this lab people, and they said that
Yeah.
the
Yeah.
PCR done in this panel is slightly different from what we do as a kind of individual this thing testings. So sometimes the
I
sensitivity
see.
can suffer. It's not
Right.
100% actually.
Ah,
Absolutely correct, sir. Absolutely.
yeah. That's interesting. You see, somewhere I read that if you do the HSV, herpes simplex virus separately,
Yes.
that
Yes.
PCR is
Yeah.
far more sensitive than
Absolutely.
if you do the HSV PCR as part of that 14 organism panel.
Absolutely, sir. Same thing about the crypto. All this biofire panel. They also have two I think fungal. One of them is our
Yes.
protein.
Yes.
Crypto. Crypto is often falsely negative.
Yes.
We need to ask a kind of separate
Right.
cryptococcal antigen if you have a clinical suspicion.
Separate. Absolutely correct. Absolutely correct. Absolutely correct. Yeah, good thought.
I think the next topic is taken by Atish under the guidance by Dr. Rakesh Singh. They're talking about encephalitis and brain abscess. Atish, are you there? Yeah.
Yes,
there.
sir. Very good morning, all teachers. Sir, my slides are visible.
Yes, Atish.
Yeah, slides are visible. Yeah.
Thank you, sir. Sir, today I am presenting topic on encephalitis and brain abscess under my guide, Dr. Rakesh Singh, sir. Sir, in a practice, there is a little distinction may initially be seen between the meningitis and encephalitis. In the term meningoencephalitis, we often use as a catch-all. Differentiating between viral meningitis and viral encephalitis is arguable, more important than determining which virus is causing that disease, because the encephalitis has a dreaded complications versus the meningitis. So we have to differentiate between the two infections. Encephalitis caused by the viruses, in contrast to viral meningitis, can be life-threatening and resulting in permanent neurological damage. Neurological examination imaging can provide a powerful clue into the etiology of viral encephalitis. if obtained at the right point in time. Additionally, a throughout history of area of residence and the travel is also important. Some viral encephalitis are some region bound and seasonal dependent in manner. This chart is showing some common viruses with viral endemicity, seasonality, and transmission patterns. Rabies has no seasonal variation. The transmission is usually due to infected mammals, contacted persons, or blood transfusion. And usually the pattern of involvement is encephalitis. In the West Nile virus, it is usually in a summer, and it can cause both encephalitis as well as meningitis. Paucian virus usually causes encephalitis. St. Louis virus causes encephalitis. This is also again a chart showing the common viruses: measles, mumps, rubella, Zika. They are all the seasonal and regional bound, and causing meningitis as well as viral encephalitis. Now coming to a detail of each encephalitis and their pattern and their clinical presentation. HSV encephalitis is most common cause of sporadic encephalitis in the immunocompetent adults, usually characterized by prominent gustatory and olfactory hallucination, anosmia, memory disturbances, and focal deficits. The bizarre behavior with the personality alteration are also seen. The HSV encephalitis can trigger the NMDA encephalitis. The HSV PCR is done for diagnostic confirmation. This is the MRI showing the most common involvement is temporal, bilateral temporal involvement is seen predominantly in the HSV encephalitis. And this is the EEG showing the temporal spikes, periodic sharp wave, and complexes discharges are seen in the temporal regions. This is the again picture MRI of the patient of varicella zoster virus affecting the temporal as well as the perisalvian areas. The treatment for the HSV encephalitis or any viral encephalitis, usually we start with a dose of acyclovir. We consider acyclovir in an adult at a dose of 10 milligram per kg, which is given every 8 hourly, which is diluted in 100 cc of NS over 1 hour, and the duration of the therapy is 14 to 21 days. And in the neonates, the dose is 20 milligram per kg of IV acyclovir, which is given every 8 hourly for a minimum of 21 days. For adults, it is 14 to 21 days. And in a neonates, the dose of 20 for 21 days. Then the rabies. Rabies is caused by single-stranded RNA virus. The presentation is diffusely severe, uniformly fatal encephalitis. The rabies encephalitis is still the most common viral encephalitis in many developing countries. The dogs are the primary carriers. The bats, raccoons, chunks, and the foxes are also the carriers. The cases of transplant-associated rabies have also been documented. The initial symptoms of fever, pain, and paresthesia at the inoculation site is usually seen. This picture is the picture is of negri bodies. The rabies usually replicate in the peripheral nerves, and then it ascends towards the cortex. There are two forms of the rabies encephalitis. One form is showing the agitative behavior, excitable behavior, hydrophobia, aerophobia, and second form is showing the paralytic form, which is much slower in course, and the paralysis usually start from the bitten limbs, and then progressive paralysis is seen, which can often lead to coma and death in later on stages. The rabies infection, as universally described, is a universally fatal disease. Rabies infection is 100% preventable. The post-exposure prophylaxis is not effective once the virus has reached the nervous system. The milk cow protocol, which is also described in the previously, it usually combined with the midazolam and the ketamine to usually paralyze the patient and avoiding the agitated behavior for the patient. And it is found that in some single survivor of a rabies patient is found till now. There is one case also reported in 2017, the AIMS Rishikesh. The paper is published by the Dr. Pandya sir, and they have tried this Milky Way protocol in the rabies patient, and they have shown that the patient has recovered his cognitive and behavioral up to some extent, but later on they could not follow up that patient because the patient went DAMA. So one paper is published by the AIMS protocol based on this protocol therapy. Both post-exposure as well as the pre-exposure prophylaxis for the human is available. The vaccination of animals is important in treatment and management protocol. The risk factors and exposure management and diagnosis of the rabies infection is the risk factors. The penetrating exposure of infected saliva is usually managed. There are some exposure categories: category 1, category 2, and category 3. In category 1, there is no breach of the human skin or the mucosal membrane, minor scratches or the abrasions. And category 3 is very dangerous. Breach in the human skin, mucous membrane, any exposure to the bite is considered as a category 3 bite. Then pre-exposure management, the yearly vaccination of dogs, means domestic animals, then human vaccination, pre-exposure, veterinary doctors or rabies laboratory workers, travelers, and post-exposure management in the humans in category 1. We usually don't give any post-exposure management. In the category 2, immediate throughout the washing and the vaccination is given. And category 3, throughout washing, vaccination plus administration of rabies immunoglobulin is included. The pre-exposure prophylaxis consists of 3 doses of vaccination with a periodic booster depending on the immune response. The post-exposure prophylaxis consists of immediate and through wound washing along with 4 doses of rabies vaccination over the course of 2 weeks, and in some cases concomitant administration of rabies immunoglobulin according to the category is determined. Now the coming to the next virus, that is the arbovirus. These are carried by the mosquito, tick vectors, and a variety of the human diseases. Many they can cause encephalitis as well as meningitis. Worldwide, the primary neurotropic viruses are JE, Japanese encephalitis, tick-borne viruses, and West Nile viruses. The very common, which is now emerging, is a Zika virus, and old one is the chikungunya and the dengue virus. After inoculation, the incubation period of usually ranges for the arbovirus is between few days to few weeks, which causes followed by non-specific febrile illness and the progressive neurological dysfunction, including headache, meningismus, seizures, and cerebellar or the cortical function loss. This is the MRI picture showing arbovirus pattern of encephalitis, showing this T2 white matter hyperintensity with in the basal ganglia and thalami. The CSF picture may initially in a viral encephalitis is usually neutrophilic if it is tested very early, and that will then it will later will involve into lymphocytic pleocytosis. This is a MRI picture showing double Duffnet sign in dengue encephalitis. Showing there is blooming on a GRE sequences, and ADC shows the restricted diffusion. Microimages are also seen. This is an MRI picture showing a patient with a Japanese encephalitis with proven Japanese encephalitis with Parkinsonism and dystonia, and it is showing the flare hyperintensity in the bilateral thalami. CSF can be tricky, and it can be confused with the bacterial cause also in the early stages, but later on the lymphocytic picture will predominate. The recent case-based evidence suggests that for a treatment purpose, IV immunoglobulin is suspected in arbovirus encephalitis and may have accounted for the favorable outcomes. So IG plus corticosteroid can be tried. The West Nile virus. In the Western countries, the most common neurotropic arbovirus currently is West Nile virus, which can cause meningitis as well as encephalitis. Since the West Nile virus has spread across the entire continent carried by the Culex mosquito, the risk factor for the West Nile virus is the immune compromised system, extremes of age, or underlying diabetes mellitus, or any comorbid state. The patients are high risk for the West Nile viruses. The asymptomatic West Nile viruses is also quite common. The CSF IgM antibody test is usually diagnostic. This is the MRI picture showing the West Nile virus affection encephalitis with Parkinson's feature, and there is characteristic involvement of the substantia nigra and bilateral thalami. The The Powassan virus. The Powassan virus is emerging encephalitis and is a flavivirus. It is caused by the isodix ticks, which is the same tick which is causing the Lyme's disease. The difference between the two infections is that this virus transmission is thought to occur very quickly within an hour after the tick exposure, as compared to the Lyme's disease, which is caused later on after a few days. So this virus can cause the encephalitis as well as cerebralitis, but this does not cause any meningitis. The St. Louis encephalitis. This virus is a flavivirus which is caused by the Culex mosquito, and the presentation is similar to West Nile viruses in terms of the risk factors and disease presentation. Mostly are asymptomatic. It can also cause encephalitis or flaccid paralysis, as well as it can lead to meningitis. The Eastern equine encephalitis, as its name suggests, the host is comes from the horse, and it is very common in the east coast of the United States. It will leads to encephalitis, meningitis, and acute flaccid paralysis. But the mortality for this virus is very high. The Zika virus. The Zika virus is new emerging virus, and it has gained a very importance worldwide. It is a flavivirus transmitted by the Aedes mosquito, and the sexual transmission also reported. It is not a primarily encephalitis virus in the adults. Usually, it will lead to febrile illness followed with a rash, joint pain, and neurological diseases in the adult is also typically manifested with Gulen-Bled GBS-like presentation. The maternal transmission is very crucial as it will lead to devastating encephalitis in a developing fetus, which lead to microcephaly. The risk to the fetus is not entirely understood, but they estimated that approximately 3% of the babies born to the mother infected during the pregnancy have the microcephaly. There is disordered neuronal migration and developmental restriction, causing lesencephaly, polymicrogyria, pachygyria. The prevention of the maternal infection, whether by the mosquito or the sexual transmission, is strongly recommended. Other arboviruses, Japanese GE viruses or tick-borne virus encephalitis is probably the most common additional arboviruses worldwide, and both are the flaviviruses, and both are vaccine preventable. Now the lymphocytic LCV virus, that is lymphocytic choriomeningitis virus, LCMV. It predominantly causes the viral meningitis. It rarely causes the encephalitis, and transmission is by the virus inhalation in the setting of close contact with the infected rodents or infected organ donors. The fever, general symptoms of fever, malaise, headache, and later meningismus may emerge. The CSF classically demonstrate the lymphocytic pleocytosis with elevated proteins. And imaging from the fetus infected with the viruses shows the hydrocephalus periventricular calcifications and gyral or the cerebellar abnormalities. Ribavirin, once the diagnosis was known, can be tried in these patients. The enteroviruses. Enteroviruses is the genus of Picorna viridae family, and the common ones are the Coxsackie viruses, ecoviruses, polioviruses, and rhinoviruses. The route of transmission is fecal or oral, followed by the replication of these viruses in the gastrointestinal tract, and then subsequent dissemination. The usual presentation for these are viral meningitis, poliomyelitis, or rarely or occasionally encephalitis. The most notable viruses in this group are enterovirus 71, Coxsackie A6, A16, and ecoviruses 9 and 11. Usually the systemic symptoms of hand, foot, and mouth disease can have. The encephalitis usually tend to involve the deep gray white matter and brainstem. This is the picture of CME encephalitis, usually causing the ventriculitis and ventriculomegaly. This is the ventriculitis with pattern involvement in CMV encephalitis. Now the measles. The measles is usually seen in the children's. This is usually caused by the paramoxyviruses that usually trigger a high contagious exanthematous viral infection characterized by generalized rash lasting for 3 or more days with fever, cough, coryza, or conjunctivitis. The pathognomic lesions on the buccal mucosa, the coplic spots are usually present, The acute encephalitis as a complication of the measles infection is rare and occurs around the time of rash appearance. The laboratory diagnosis of measles is usually done with IgM serology or viral isolation using the PCR detection. In addition to the acute viral presentation, the measles also rarely causes both a subacute encephalitis within a year of infection and chronic encephalitis after a year of infections. The Adam-like presentation is also seen with a post-infective as a post-infective process due to the autoimmune phenomenon. The primary measles encephalitis is usually by the inhalation of the aerosolized droplets, which are picked by the pulmonary system and carried to the lymph nodes, and then from where the viremia occurs. The survivors sustaining the permanent neurological sequelae. The measles inclusion body encephalitis is a subacute encephalitis that occurs within a year of infection. It usually occurs in a immunocompromised and extremely high morbidity. It usually have extremely high morbidity and mortality rates. The SSPE, which occurs years after the initial infection and which is a progressive and a fatal disease characterized by progressive cognitive impairment that eventually lead to myoclonus, and this is very rapidly progressive disease. The post-exposure prophylaxis with the MMR, measles, mumps, and rabies vaccination within the 72 hours of exposure is recommended for the unvaccinated person. The immunoglobulins is also recommended, but not eligible for MMR post-exposure prophylaxis patients. The mumps and the rubella. The mumps and the rubella are the like measles. It also causes the exanthematous febrile infections. Both are preventable by the live attenuated vaccine which are available. The mumps is a paramexovirus, while rubella is like Eastern equine encephalitis virus is a toga virus. These infections rarely involve the nervous system. These are peripheral diseases. But if involved, it can have meningitis as well as the encephalitis pattern, but usually they are benign and self-limited. Rubella most frequently lead to is a intrauterine infection and congenital rubella syndrome. It has presentation and it can lead to the static encephalopathy later on. Rubella, similar to SSP, the rubella can also cause a chronic progressive encephalitis. Now this is a very important slide. It is showing the CSF correlation for different types of the viruses. Now, if the cells are more than 1,000 per if the cells are more than 1,000, then mumps or LCMV virus infection should be thought of. If atypical lymphocytes are seen in the CSF, then Epstein-Barr virus or the cytomegalovirus virus should be thought of. Plasmacytoid cells are also causes the mollaret-like cells. These are atypical atypical macrophages cells. These are seen in the West Nile viruses. Then the neutrophilic pleocytosis is seen in characteristically in the West Nile virus and cytomegalovirus myeloradiculitis. The non-traumatic hemorrhagic CSF, it is seen in the HSV, and when the glucose is low, we have to think of mumps, LCMV, and CMV. The varicella zoster encephalitis, it is your HSV3 virus with multifocal areas of hemorrhages and ischemic infarctions due to this due to CNS vasculopathy. The predominant cerebellar involvement is usually there, and usually it won't appear with the rash. Romaine encephalitis. When the presentation of the patient is with the romaine encephalitis, then think of Listeria monocytogenes, enteroviruses 71, rabies, and flavivirus. Then coming to the next topic, brain abscess. The brain abscess are serious, potentially life-threatening infections of the central nervous system. There are now introduction of CT, minimal invasive stereotactic guided aspiration, and newer antimicrobial have now improved the mortality rates. The supratentorial abscesses are more common than the infratentorial, and the single lesions are more common than the multifocal in a presentation. The usually the spread of infection is contagious spread or hematogenous spread. So the contagious spread from the ear due to otitis media or mastocytitis, and hematogenous spread due to the endocarditis or pulmonary or abdominal or skin infections, or penetrating head trauma after neurosurgery. It can also be a cryptogenic when the no source is identified. The abscess related to the contiguous sites are usually solitary. The hematogenous spread causes the multiple abscesses at gray white matter junction and border zone vascular territories. In case of contiguous spread, the abscess is typically adjacent to the source of infection. The frontal lobe is most common cause site of abscess along with the temporal lobe when it is associated with the chronic sinusitis. Abscess associated with the otitis media are usually in the temporal lobe and cerebellum. The clinical presentation usually has a patient has a triad of fever, headache, and focal neurological deficit. But this triad is not we didn't find this triad in many of the patients. So it is neither sensitive nor specific. The headache is the single most frequent symptoms, whereas fever may be absent in more than half of the cases. The MRI is ultimately the diagnostic choice, and MRI usually picks up the early cerebralitis pattern of involvement also. The role of a lumbar puncture is also concerned, but the lumbar puncture role usually came in a picture when there is abscess rupture or concomitant meningoencephalitis is present. Otherwise, lumbar puncture won't help much. So it usually shows a mild pleocytosis with elevated proteins. The blood and the abscess culture has a good role in diagnosing this. The stereotactic guided aspiration and the drainage can both has diagnostic and therapeutic functions. There are the organisms Staphylococcus species, Staphylococcus aureus, Staphylococcus epidermidis are often isolated from the post-surgical abscesses. In the anaerobic infections from the oropharyngeal or the gastrointestinal source, like the Fusobacterium, Actinomycetes, bacteroids, and Peptostreptococci tend to predominate in the anaerobic group. Among the immunocompromised population, we have to think of Nocardia, Rhodococcus, and Mycobacterium avium complexes. The fungal pathogen also we have to think in a mind of Aspergillus candida, Cryptococcus, Fusarium, and amoebic infections like Acanthamoeba species and Balamuthia species. Now this is the table showing the route of transmissions with their pathogens and the treatment. Now usually for the streptococci, the antimicrobial regimens of cephalosporin, including a third generation ceftriaxone, with added for the anaerobic coverage we had metronidazole and add vancomycin if the staphylococcal aureus is suspected. And from the autogenic cause streptococcus we have to and this is again another slide showing Staphylococcus group of infections where we consider vancomycin, ceftriaxone, and metronidazole. For the now the treatment, the combined surgical and medical treatment has been traditionally been mainstay in the brain abscess management. The number, size, anatomical localization, stage of the abscess will guide for the further management therapies. Minimally invasive stereotactic guided aspiration techniques has a good result. Surgical excision is usually recommended for the posterior fossa lesion or multiloculated abscess and superficially solitary abscess. If the abscess is small, less than 2.5 centimeter without any mass effect, with intact mental status, the antimicrobial therapy alone is guided. Now the combination of empirical therapy, therapy to for any abscess to start, it includes third generation cephalosporin plus metronidazole and addition of vancomycin if the patient has a staphylococcal infection after the neurosurgery. The meropenem can be used as a broad spectrum cephalosporin if metronidazole or cephalosporin is contraindicated. The repeat imaging you have to do after starting the antimicrobial within 1 to 2 weeks. The role of corticosteroid is not included. Actually, it is used for just for the decreasing the edema around the, but the risk and the benefit ratio we have to consider in a mind, because it can flare up because steroids inhibit the encapsulation, circumscription, and granular formations. The factor associated with the poor outcome in a brain abscess patient, the underlying systemic illnesses, ventricular rupture of the patient, if the GCS score is less than 9 at the time of presentation, and hematogenous spread of infection is there, then it will cause a poor outcome in a patient. Now we'll discuss 1 to 2 cases. A 61-year-old gentleman with CLL leukemia has treated with rituximab and 1 week has a history of presented with 1 week history of headache, which is posterior predominant with nausea, vomiting, dizziness, and confusion, without any history of fever, chills, or neck stiffness. On examination, he has dull sensorium with left-sided cerebellar signs. Now, this is the MRI picture showing the ring enhancement region in the posterior fossa in the cerebellum on the left side of the cerebellum, and these lesions are multiloculated. The WBC count, ESR, CRP both were raised. The surgical excision is done as the lesion is in the cerebellum and in the infratontine cerebellum lesion, and the cultures grew nocardia species, and the patient is treated with a prolonged therapy with a meropenem followed by trimethoprim and sulfamethoxazole combination, and shows the excellent response. So the here the important point is that the fever was absent despite a peripheral leukocytosis and extremely elevated inflammatory markers in this patient. So next case is a 41-year-old gentleman with a history of chronic alcoholism, presented with 3 days history of progressive confusion without any history of any systemic features of fever, chills, neck stiffness, cough, or rash, or abdominal or ear infections. On arrival, patient is febrile but has a poor dentition, and the patient has a frontal features of Luria manual sequencing task is deranged with mild pyramidal pattern of left upper extremity weakness. On MRI imaging, the patient is showing multifocal and multiple ring enhancement lesion with some mild edema, with edema around it, and with vasogenic edema. And the largest lesion is in the right frontal lobe. WBC, ESR, CRP both were elevated, but blood cultures for this is negative. Then stereotactically, the cultures from the right frontal lesion is taken, and it grows the fusobacterium, and the patient is treated with meropenem and metronidazole therapy, and later on to metronidazole monotherapy. For a total duration of treatment is given 16 weeks, and the patient improved, and follow-up MRI shows the gliosis. So this was a case of a cryptogenic brain abscess. Usually the source is not found, but usually we think of any hematogenous spread of infection as the lesions are multiple and bilateral. This is again one third case. This is most common most common bacteria causing this infection, Streptococcus emaitis. Usually this picture I have added because the MRI is showing ventriculitis in this. So this is the Streptococcus emaitis causing the brain abscess with ventriculitis. So thank you.
Yeah, yes, Satish, well done. Very nicely covered. I have one comment to make, sir.
I
Now-
love emphasis on rabies. I loved it. Yeah.
Yeah, yes, sir.
Marvelous.
Now, many of these encephalitis, we don't actually see them. But nowadays, because of the changing, I think, demographics and extensive travel of people, I think many of these, the travel history becomes very, very important. If somebody has gone abroad and come back, then I think we'll have to suspect some of those viruses which are more prevalent there. And I mean, recently I know Dr. Rajesh Benny, and he had diagnosed one actually Lyme's patient had come with only I think foot drop, and he had traveled to USA, and it was a Lyme's induced basically radiculitis causing a foot drop. So I think most of these infections which we don't see, we may be seeing them now more commonly because of travel. That was one point. Secondly, I wanted to ask one question: the role of IV steroids and IV IG in these patients of viral encephalitis, when we have maybe a positive HSV1 or maybe JAB-B, how safe and how effective they are if we use in our patients? That was one question I wanted to ask. What do you think, sir?
I have never used it, and I think it's very, very tricky to use it because of so many reasons. Number one will be, but it will be used as an error when we get confused between autoimmune encephalitis and infective encephalitis.
Yes, sir.
That can happen to us. In sometimes it can happen sometimes even to the best of us. In some situations, some clinical situations. So very often we see patients who are half treated somewhere else and they land with us. So we're not exactly aware of what exactly happened and what the reports were. So that would be a situation, but I don't think there's any evidence to support this. Is there any evidence? Have you tried it?
Now, sir, now preparing for this talk, some of the West Nile encephalitis, because there is no treatment, they have shown favorable outcome after giving IVIG. So we don't know still.
Has favorable outcome be reported?
Yeah, I think Atish has mentioned that.
So hats off to Atish. You tried a small review on this.
Sir, some patient in that article in a continuum, and it is written that the recent case-based evidence suggested that early initiation of IVIG in a suspected arbovirus encephalitis may have accounted for favorable outcomes. But sir, some patients have shown the response. Sir.
Good point. I was not aware of this. Yeah, good point.
And sir, HSV encephalitis usually trigger the NMDA, so might be that will be the
errors
reason
can happen,
that
positive and negative. Yeah.
Yes, it is.
But sir, one point was that, is there a risk of worsening of the viral, I mean, replication if we use steroids and IVIG in patients who have a proven viral encephalitis? That is also a risk, little bit mentioned in the books, that steroids can sometimes, increase the replication of the virus itself.
I think so. I'm with you there. Who's next now? I think it's on Darshan is talking on. Hello, Darshan, are you there?
Yes, sir.
Yeah. So I think Darshan is talking on the
Are my slides visible, sir?
Yes, of course.
Yes. Good morning, everyone. Today I'll be give a talk on infections of the peripheral nervous system. So although these are rare, but they are important to be recognized as many of them are treatable. The outline would be in 5 parts. First, we'll talk regarding infections of anterior horn cell, then involving nerve root or plexuses, then infections of peripheral nerves, neuromuscular junctions, and lastly of muscles. So first we'll talk regarding anterior horn cells infection. So phenotype is of acute flaccid paralysis and prototypical disease is polio. Now it's quite rare because of the vaccination. There is near global eradication, and lastly in 2019 only 175 cases were reported, mainly from Pakistan and Afghanistan. It has come from the Greek word polio means gray, and it's an exclusive human disease transmitted through fecal-oral route. Manifestation vary from asymptomatic to most severe form of debilitating paralysis. There is extensive damage to anterior horn cell. In the bulbar form, there is brainstem involvement, it could be fatal. And this widespread muscular atrophy can lead to flaccid paralysis. There's also entity of post-polio syndrome, usually occurs after 25 to 30 years after the initial paralytic attack. Usually involves the same limb that affected the polio, but sometimes in some patients, other limbs can also be involved. And due to ongoing motor degeneration, progressive muscular atrophy is seen. Other in anterior cell is West Nile virus, not common in our country, but it is most common viral cause of acute flaccid paralysis in adults in US. It presents with acute flaccid paralysis in the form of monoplegia, diplegia, triplegia, or quadriplegia with occasional brainstem involvement and respiratory failure. Mainly the cycle involves birds, mosquitoes, but incidentally humans and horses can be affected. Other anterior cells, arboviruses can cause acute involvement like Japanese encephalitis, dengue, rabies, tick-borne encephalitis. These all are acute presentation, and presence of meningoencephalitis in addition to flaccid weakness is typical, but not always present. And if there is chronic involvement of anterior cell like picture, then there should be a suspicion of HIV or HTLV can present similarly. If there is a situation, then there is less occurrence of concurrent encephalitis. So this was about anterior cell. Second, we'll talk regarding infections of the roots and plexuses. Radiculopathy and polyradiculopathies are much more common than the plexus involvement. Here, bacterial infection Lyme's is quite common. It is clinically similar to structural radiculopathy. There's a preceding rash, classically what we call erythema migrans, with a target-like appearance. There's a exposure of tick Borrelia burgdorferi history. It is quite prevalent in Northeast US, and the most common cranial affected in this is the 7th. What are the clues to the diagnosis? Enhancing nerve roots in the MRI, no clear structural cause, CSF showing lymphocytic pleocytosis or normal or elevated protein finding, and EMG usually preganglionic pattern. Second, in radiculopathy, varicella zoster is quite common. The rash is different to that of Lyme's. It is dermatomal. It is quite painful, burning vesicular rash, and most frequently thoracic dermatomes are involved in varicella zoster. Here, it is post-auricular, like Ramsay picture is seen. Weakness in the distribution of nerves or nerve roots is seen in minority of the patients. More is rash and pain. If the diagnosis is unclear, and if the CSF is obtained after 14 days, then varicella zoster virus IgG, it could be compared between serum and CSF to evaluate whether there is any intrathecal production or not. IgM antibodies can be considered, but the sensitivity is low. If there is positive, it shows active infection. PCR for VZV DNA can also be done, but it's also having low sensitivity. In the MRI, it shows nerve root enhancement plus concomitant spinal cord lesions consistent with myelitis. Acyclovir is the treatment of choice. Other herpes viruses like HSV1, HSV2, CMV can lead to radiculopathies. HSV2 particularly can cause genital herpes, and what we call Ellsberg syndrome entity can be caused by it. That is acute lumbosacral radiculitis because of HSV2. And it's a reactivation syndrome, usually present with acute urinary retention, constipation, and saddle sensory disturbance. And at the time of presentation, genital ulcers may or may not be present. EMG suggestive of radiculopathy, MRI suggestive of smooth nerve root enhancement. And acyclovir usually shortens the course, but recurrence are quite common in this Ellsberg. Cytomegalovirus can also cause lumbosacral polyradiculopathy, particularly in immunocompromised HIV patients are at more risk. And there is enhancement of cauda equina. There is polymorphonuclear pleocytosis and elevated protein levels in the CSF. In the CME, positive CMV PCR is quite diagnostic, and otherwise, if there is any evidence of infection of CMV elsewhere in the body, like CMV retinitis or colitis, that is also a supportive feature. Ganciclovir and foscarnet used for CME infections, but here also most patients have residual deficits. TB can cause radiculopathy due to vertebral compression from Pott's disease, like myeloradiculopathy, or arachnoiditis with predilection for cauda equina. And this spinal meninges involving TB, either it can occur de novo or as a part of TBM. And this de novo spinal meningitis, it could be rapid or slow, it could be single or involving multiple levels, it could be of ascending or transverse radiculomyelopathy. So these are regarding 2 points, anterior cell and roots and plexuses. Third would be, we'll talk regarding infections of the peripheral nerves in 4 points, cranial neuropathies, mononeuropathy or mononeuropathy multiplex, a length-dependent axonal neuropathy, and demyelinating neuropathy. So cranial neuropathy, it can occur in isolation or as a part of wider involvement of generalized peripheral neuropathy or due to meningeal infection. And infections can directly damage the cranial nerves, or as a part of immune response, the neuropathy occurs. Facial nerves is most commonly affected. Leprosy and diphtheria directly affects the nerves. Cryptococcal, TB, syphilis. Here the cranial neuropathy is usually due to secondary to meningeal infection. Other bacteria and viruses also can cause. We'll talk regarding few. Coronavirus, it is known as a neurotropic virus also, and quite common. Different CNS and PNS manifestations are common. It enters the cells of peripheral central nervous system using ACE2 receptors. Anosmia in up to 50% of patients of COVID we are seeing. Present literature reports almost all cranial nerve involvements COVID-19. There is some early involvement and some nerves are late involved. Loss of taste and smell is early, and ophthalmoparesis, dysphagia, vision loss, hearing loss are late involved. And recent systematic review noted that 3rd, 6th, and 7th are most commonly involved nerves in the coronavirus. Second, in cranial neuropathy, herpes virus, herpes zoster, that is shingles, it is caused by varicella zoster virus reactivation. It stays latent, and due to immunocompromised state, it can reactivate, or any other if patient is on any immunosuppressant medicine. Herpes zoster ophthalmicus is most important, and why it is most important? Because if it is involving the V1 division of trigeminal, then there is a high risk of compromisation of vision, also due to optic involvement. And Ramsay-Hunt syndrome, it is most commonly, it is associated with varicella zoster, and there is a triad of 3 things: facial palsy, vesicular eruptions on the auricle, and 8th nerve palsy also. In this varicella zoster virus reactivation commonly affects 5th and 7th nerve. And if it is involved in the V1 division, it's a ophthalmic emergency also. Here in the MRI, you can see that the internal auditory meatus 7th and 8th nerve complex is affected, along with cochlea and on the left side. TB can also cause cranial neuropathies in 30% patients of CNS TB. It is one of the commonest cause of multiple cranial nerve involvement in tropical countries. Commonly involved nerves are 2nd, 7th, 3rd, and 8th in isolation or in various combinations. Most of the cranial neuropathies in TB improve without any sequel. Here you can see basal meningitis. Other infections like syphilis involve 7th and 8th nerve commonly. Neurobrucellosis, 6th and 8th nerve is most commonly involved. Fungi like mucormycosis and parasites like neurocysticercosis also can lead to cranial neuropathy. Next, we'll talk regarding mononeuropathy or mononeuritis multiplex. Here, the prototype will talk regarding leprosy, hepatitis B and C, and Lyme's, HIV, CME. These all can lead to mononeuritis multiplex. So leprosy, it's a chronic infectious disease caused by acid-fast bacteria, Mycobacterium lepra most commonly, and less often by lepromatosis. Droplet spread is the main mode of transmission, but the disease transmission is not fully understood. Armadillos are animal reservoirs, and it may transmit the disease to humans. Infection incubation period is quite long, but majority of people has developed immunity and thus do not develop symptoms. And BCG vaccine, it is partly protective for leprosy. So how it is classified there are 3 classifications. First is Ridley-Joplin, that was it uses combination of clinical findings, histopathology, and bacterial load. And there are 5 types. Tubercular leprosy is in the one end of the spectrum with preserved cellular immunity, and lepromatous leprosy, it is in the opposite hand with poor cellular immunity and high bacterial index. In between, there is borderline tuberculoid, there is borderline and borderline lepromatous leprosy. WHO classification is more of for a therapeutic purposes. It divides into 2 types: possibacillary and multibacillary. If there is 1 to 5 skin lesions and negative skin smear, or if there is peripheral nerve involvement absent or only 1 nerve is involved, then it is possibacillary. And if it is more than 6 lesions or positive skin smear at any site, irrespective of the skin lesions, then it is multibacillary. If there is 1 nerve, more than 1 nerve involvement, irrespective of the skin lesion, then it's also multibacillary. Also, the Indian classification also includes indeterminate and pure neuritic types, apart from tuberculoid, borderline, and lepromatous. So clinical features, there is combination of skin lesions and neuropathy. Skin lesions associated with hypo or anesthetic patch, which is situated on the back, buttocks, trunk, face, earlobes. These are common site. Temperature sense is most commonly affected. Pure neuritic variant, usually there are no skin lesions. Cooler areas of the body are predominantly affected. It can also involve anterior chamber of the eye. So it is an important preventable cause of blindness. So one must keep in mind. Classical facial features like thickened skin, exaggeration of skin folds, loss of eyebrows and saddle nose, and leonine phases of leprosy in lepromatous leprosy. The clinical spectrum of neuropathies in leprosy, it is quite extensive, but it usually presents with negative symptoms like numbness, anhidrosis, painless wounds, anesthesia or hypoesthesia, and patchy motor deficit. If there is positive sensory symptoms, which is less common, then one should herald the beginning of lepra reaction. One should keep in mind that it predominantly affects the small fibers in a non-contagious manner. The kinesthetic sensations are preserved till late, joint position vibrations, and impairment of temperature is first affected, then touch, and then pain. Partial involvement of nerve is very common. Pure motor involvement is very uncommon. So there is a spectrum of clinical presentation of leprous neuropathies. Common are mononeuropathy, mononeuritis multiplex, thickened nerves, non-healing ulcers, cranial neuropathies, trophic changes, negative symptoms, patchy nerve affection, temperature sense widely affected, and sparing of proprioception and DTR also preserved. Uncommon is pure neuritic, symmetric polyneuropathy, pansensory, autonomic, leprous ganglionitis. These are uncommon. Here the photograph is showing thickened greater auricular nerve. Greater auricular nerve is better seen than palpated among the thickened nerves. The second photograph is showing right-sided isolated eye closure weakness. It is leg ophthalmos with lower half of face is spared. This patchy facial nerve involvement. And there's also a wasting of first dorsal interossei muscle in the middle second figure, and there's type 1 lepra reaction, facial swelling and redness in the last right figure. So thickened nerves, it's a most important clinical sign in leprosy. 40 to 75% of affected individuals in endemic area leprosy patients, thickened nerves are present. Tenderness of thickened nerves associated with beaded appearance, it strongly favors leprosy. There is single nerve only, then tuberculoid is likely. If there is symmetrical extensive involvement, that is lepromatous. After treatment, nerves gradually tend to shrink, but they remain abnormally firm. So which are the nerves that have predilection for thickening? One is greater auricular, it is better seen than palpated. Ulnar nerves just above the elbow, dorsal cutaneous branch of the ulnar nerve at wrist, median, superficial radial, superficial peroneal, lateral popliteal, posterior tibial sural. These are commonly thickened nerves. Cranial neuropathy common is facial, trigeminal and olfactory. Facial nerve zygomatic branch which supplies the orbicularis oculi is the most frequently affected. There is also associated sensory impairment or hypopigmented or hypoaesthetic patch in the territory of trigeminal, particularly in the maxillary branch. So there is a patchy involvement with lower half of face is spared. Talk regarding lepra reactions. There are two types: reversal reaction, that is type 1, and ENL, erythema nodosum leprosum, that is type 2. Reversal reaction is more common in borderline lepromatous or borderline tuberculoid, and in lepromatous leprosy, ENL is more common, and reversal is gradual. Type 2 is sudden, and in reversal reaction there is increased inflammation of pre-existing skin lesions, and where there is in ENL there is new erythematous skin lesions plus there is systemic involvement, and prognosis is better in type 1, and type 2 it is worse, and it could have chronic or recurrent course. So definitive diagnosis is made by skin or nerve biopsy showing acid-fast bacilli. Sometimes bacteria may not be found, particularly in tuberculoid, in which case particular histological features like globi or dense foci of lymphocytes can be seen. And Mycobacterium lepra PCR measured in biopsy samples may be useful to support the diagnosis when there is atypical presentation or histological features not present. Here, USG of the ulnar nerve showing focal thickened ulnar nerve, and below there is thickening of left-sided median nerve and also in the visual branch of the palm. So for treatment now, only duration is the difference. For possibly 6 months and for multivascular 12 months with Dapsone 100 mg daily, clofazimine 50 mg daily, and monthly 600 mg rifampicin and 300 mg clofazimine. Now we'll talk regarding hepatitis C, which is causing mononeuropathy multiplex more of in 10% of patients associated with quite prominent pain. Mixed cryoglobulinemia is present, and it usually in the nerve biopsy there is a vasculitic involvement, vascular inflammation. So treatment of underlying hepatitis C virus infection plus immunomodulation may be helpful, but the data is limited. Hepatitis B is also associated, particularly with vasculitic neuropathy and also rarely with CIDP. There is a definite association in 25% with polyarteritis nodosa. So use of antiviral plus 2 weeks course of corticosteroids and plaques may be considered. And in the neuropathies, length-dependent external polyneuropathies, some infections, particularly this here, HIV, hepatitis C, leprosy rarely also can cause, HTLV1 and Lyme's can cause. Demyelinating neuropathy, it could be para-infectious or post-infectious demyelinating. Some infections like HIV, hepatitis B, hepatitis C, HTLV1, these are associated with CIDP. And the infections associated with AIDP, we all know. In diphtheria, there is a demyelinating neuropathy with unique biphasic course. So we'll talk regarding diphtheric neuropathy. It is caused by release of diphtheria exotoxin, which is produced by Corynebacterium diphtheri. It invades the Schwann cells and it inhibits the synthesis of myelin proteolipid and myelin basic protein. Particularly, the incidence of diphtheria is decreased because of quite expanded access to vaccination. And usually it was more common in children and young adults, but because of revaccination and waning immunity, there is lack of revaccination. There is a demographic shift from younger to older patients. Patients typically present with flu-like symptoms, cervical lymphadenopathy, exudative pharyngitis that can lead to airway obstruction. It could be life-threatening. Here, main focus is that it is a biphasic neuropathy, usually occurs after 3 weeks, ranging from 10 days to 3 months after initial symptoms, in variable presentation. If there is a severe diphtheric illness in 70% patient, it can occur. It is biphasic. First start with craniofacial, with cranial nerves firstly affected, numbness in the tongue, dysarthria, dysphagia, bulbar dysfunction, pupillary accommodation dysfunction, oculomotor palsy, respiratory failure that can occur in the first stage. And after the initial bulbar features, more diffuse neuropathy occurs, that is in 80%. That is involving sensory, motor, and autonomic nerves. So it is in biphasic. So throat culture can confirm the diagnosis of diphtheria, especially if in the pharyngeal stage of the disease, but it can be negative. It doesn't rule out. And finding on nerve conduction study and CSF are similar to GBS. Treatment with diphtheria antitoxin and antibiotics, it should be started as soon as possible. There's a suspicion. And usually a good prognosis with recovery of neurological function. Now, infections causing autonomic dysfunction, particularly Chagas disease caused by Trypanosoma cruzi. Autonomic neuropathy is quite common and also involves autonomic dysfunction in the form of cardiac and GI dysfunction. It is endemic in Latin America, more than 8 million people affected. Other infections are like HIV, leprosy, HTLV, diphtheria, Lyme's, botulism can also cause the peripheral autonomic dysfunction. And tetanus, West Nile, rabies can involve the central autonomic dysfunction, and PNS manifestations can be there. Then motor nerve hyperexcitability. Tetanus is an impaired infection that affects both peripheral and central nervous system, but it does not fit well into a specific localization, but it represents a motor nerve hyperexcitability syndrome. So we'll talk regarding tetanus in that category. It's characterized by muscle rigidity and spasms that are caused by tetanus toxin, which is produced by Clostridium tetani. These spores are present in the soils and feces, and it can germinate in wounds or minor abrasions. In 20 to 50% cases, no obvious wound or infectious source is found. Mechanism: this toxin enters the presynaptic motor neuron axon terminals through endocytosis, then through retrograde transfer, it enters the cell body of the spinal cord and brainstem, and that it impairs inhibitory neurotransmission. That leads to impaired inhibition that leads to motor nerve hyperexcitability. Neonatal tetanus, it is quite, it can occur secondary to infection of umbilical stump, and if the hygiene, proper aseptic precautions are not preserved during delivery. Symptoms usually begin 7 to 10 days after infection and progress for 2 weeks, with recovery beginning after about 1 month. Symptoms begin at the wound sited, but almost always generalized. Whether the site of the injury, the symptoms start and then almost it becomes generalized. trismus is present in 95% of the patient, inability to open the mouth, locked jaw. A positive spatula test in which attempting to elicit gag reflex results in patient biting down. That is quite sensitive and specific. Abnormal facial posture, that is rhizus sardonicus. Laryngospasm can occur that can lead to aspiration, airway obstruction, and it can be life-threatening. Generalized rigidity and muscle spasm results in opisthotonus. It is a dramatic arching of the back, and autonomic dysfunction is also quite common. It's a clinical diagnosis. In EMJ-NCS, there is most common continuous firing of normal motor unit potentials in agonist and antagonist muscles. CSF can be normal or elevated proteins or elevated immunoglobulins can be there. Treatment, treat the infected wound, administration of intravenous immunoglobulin and spasms and supportive intensive care. Early intubation is required, early tracheostomy and enteral feeding. Riles tube also should be inserted as soon as possible because after that it is difficult. Then we'll talk regarding infections of the neuromuscular junction. They're quite rare, botulism being most common, but it's also quite rare. So we will talk few points regarding that. It causes a presynaptic neuromuscular transmission defect leading to acute bulbar respiratory and limb weakness. And it occurs from infection with spores of Clostridium botulinum or secondary to exposure of botulinum toxin. What it does, it interferes with a snare polypeptide complex. What is snare? That is soluble and ethyl melinamide sensitive factor attachment protein receptor, which prevents fusion of acetylcholine vesicles with presynaptic membrane. So it is a presynaptic defect it causes. And there are 5 categories: infant botulism, foodborne, wound botulism, adult intestinal colonization botulism, and iatrogenic. We'll not go into details of that. And lastly, we'll talk regarding infections of the muscles. It can present acutely or chronically. Acutely, mostly viral infections can cause like influenza, bacterial pyomyositis, most commonly due to Staph aureus or streptococcus. It can occur, and infestations like trichinosis are common. So viral myositis, these are acute self-limited myositis, particularly influenza. Children, it can cause severe pain and swelling in the calves. Adults, pain is less, but proximal weakness can be there because of the myopathy, and myoglobinuria can occur. Pyomyositis, it will be focal or multifocal, associated with bacterial abscess. Risk factors is immunocompromised state, male sex, younger age, diabetes, CKD, malnutrition. Staph aureus in more than 75% of cases, followed by streptococcal. Acute focal muscle pain, swelling, fever. It can lead to disseminated infection, sepsis, multi-organ dysfunction, death. Cordyceps is most commonly affected. Muscle MRI is most sensitive in specific modality in pyomyositis. We'll talk few points regarding trichinosis. It is caused by Trichinella spiralis. It is the most common cause of parasitic myositis. It is associated with ingestion of undercooked meat, typically pork. And it starts with GI discomfort. It evolves into myalgia, generalized sickness over the course of 1 to 2 weeks. Characteristic unique finding is periorbital or facial edema. Early diagnosis is important because over the course of the disease, the larva may become resistant. Elevated CPK, leukocytosis, elevated eosinophils. These are characteristic features. X-ray can show calcification in the muscles, and serum antibodies are confirmatory, and it cannot be positive until about 3 to 4 weeks after patient is infected. So antibodies may not be helpful in the first 3-4 weeks if there is a suspicion. And albendazole or mebendazole plus 2 weeks of steroids in severe cases it is required. And few points regarding chronic myositis. HIV can lead to situation like polymyositis. It responds to immunotherapy. And in HIV, other muscle diseases associated with opportunistic infections also should be kept in mind. So because of various causes can lead to muscle disease, muscle biopsy is especially important in HIV patients. In HTLV also, myositis, chronic myositis can occur, which is accompanied by HTLV myelopathy. So myelopathy plus myositis, which is not found to be responding to immunotherapy. So I'll conclude that although the infections are quite rare of peripheral nervous system, but clues to peripheral nervous system infections, particularly specific risk factors, exposures must be kept in mind. And a timely diagnosis is quite essential so that rapid and appropriate treatment should be initiated and we can improve the clinical outcomes. Thank you.
That was fantastic, Darshan.
Thank you, sir.
How commonly you see a diphtheritic GBS-like manifestation?
Quite rare. I have not seen.
Yeah, very rare, no? But it is considered to be a kind of prototypical demyelinating neuropathy.
Yes.
It is so classical demyelinating.
Yes.
Somehow never seen, probably because of the, as you rightly pointed out, vaccination and increased awareness.
Yes.
Fantastic.
It's probably this was the toughest topic to handle because we don't approach this issue as a topic. We see isolated patients and then it's in and out. But what I liked about him that he and the author, they classified it so well and made it simpler for us, hopefully simpler for us. Yeah.
Absolutely, sir. Absolutely.
Shall we go to the toughest topic of the day? The role of infections in immunomodulatory and immunosuppressive drugs by Yash.
Very good afternoon to everyone. The topic for my presentation is neurologic infection in patients on immunomodulatory and immunosuppressive therapies. What's the purpose behind this topic to be taken? The immunosuppressive medications and selective immunomodulatory agents are being increasingly used in treatment of neurologic and non-neurologic diseases. This predisposes an individual to various infections, some affecting the central nervous system. The familiarities with this clinical and the radiological features of this infection associated with these immunotherapies is most important in practicing neurology. Early recognition of infectious complications of immunocompromise is essential to guide appropriate treatment, which may include starting on a specific antimicrobial therapy and withdrawing of the predisposing medication with transition to an alternative regimen. The therapies regulating the immune system is divided into two groups. One, broad-acting immunosuppressive therapies that affect on the multiple steps in the immune system. For example, corticosteroids. This causes decreasing progression of inflammatory cytokines, inhibit macrophages motility, down-regulates aging molecules, etc. And hence, a patient on prolonged corticosteroid therapy can have a risk of wide range of infections. On the other hand, with the selective immunomodulatory therapy that affect a particular step in the immune system, more restricted set of microorganisms can be considered. So the risk of infection in patient on immunomodulatory therapy may be limited to a specific pathogen or infectious syndrome. Moreover, when a neurological infection that can also affect immunocompetent host occurs in a patient with an immunocompromised state, atypical presentations, imaging, and laboratory findings may be seen. For example, herpes simplex encephalitis. In a patient with immunocompromise, there are less prodromal symptoms, more insidious onset of presentation, and more brain stem and diffuse cortical involvement. Now we will look at the risk of neurologic infection associated with selective immunosuppressive and immunomodulatory therapy. We will start with therapies used in CNS demyelinating therapies or autoimmune conditions. Later on, we will see therapies used in post-transplant individuals. Starting with alemtuzumab, it is a monoclonal antibody against CD52, and it predisposes an individual to viruses like CMV, HSV, and varicella zoster virus. And bacteria includes Listeria, Mycobacterium tuberculosis, and Nocardia species. Patient on alemtuzumab should receive a cyclovir prophylaxis for 1 month after treatment to prevent herpes virus reactivation. Second drug being eculizumab, it is a monoclonal antibody against complement factor 5. It predisposes an individual to meningococcal infection. So meningococcal vaccination is recommended for all patients before initiating eculizumab. Antibiotic prophylaxis with penicillin or macrolide is warranted for the entire duration of therapy with eculizumab. The next drug used for the malignant disorders like MS includes the necalizumab, which is a monoclonal antibody against alpha-4 integrin. It predisposes an individual to viruses like JC virus, HSV, and varicella zoster virus. So this factor for the development of progressive multifocal leukoencephalopathy in patients with necalizumab include elevated level of serum anti-JC virus antibodies, use of immunosuppressant or immunomodulatory therapies before the necalizumab initiation, and duration of necalizumab treatment, with median time from treatment initiation to onset of PML symptoms of 25 months. So monitoring for PML in patients on necalizumab should consist of brain MRI every 12 months and a serologic JC virus monitoring every 6 months. Next drug being the ocrelizumab and rituximab. Those are the monoclonal antibodies against CD20, which predisposes an individual to CMV, Epstein viruses related primary CNS lymphomas, JC virus, varicella zoster virus, and vaccinal virus. The fungus associated with the use of fungal infection associated with use of this includes Cryptococcus neoformans, and it can also predispose to Toxoplasma gondii, CNS toxoplasmosis. Cyclophosphamide and alkylating agent can predispose an individual to nocardia and Cryptococcus neoformans. And TNF alpha inhibitors that include sagalimumab, etanercept, golimumab can predispose an individual to HSV virus, Listeria, Mycobacterium tuberculosis, nocardia, Aspergillus candida, and histoplasma. Now we will look at the therapies used in patients with with transplant, being hematopoietic stem cell transplant or solid organ transplant. The common medications used in this group of individuals includes cyclosporin, tacrolimus, everolimus, which are calcium urine inhibitors, and it predisposes an individual to viruses that includes BK virus, CMV virus, EBV virus, HSV, JC virus, and lymphocytic choriomeningitis virus. The bacteria includes the Mycobacterium tuberculosis, Listeria, and nocardia, and fungus and the parasites include the Toxoplasma gondii and Granulomatous amoebic encephalitis that includes Balamuthia also. Other drug used in this patient includes mycophenolic mofetil, which is an inosine monophosphate dehydrogenase inhibitor. It predisposes an individual to EBV-related CNS lymphoma, lymphoproliferative disorders, and JC virus. So within 1 month post-transplant, the individuals are at risk to various infectious conditions. The drug resistance, hospital-acquired infections like candida through IV lines or nosocomial bacterial sepsis, or donor-derived infections that includes lymphocytic choriomeningitis virus, vaccinal virus, adenovirus, etc. From 1 to 6 months, because of the effect of immunosuppressive therapy and impaired cell-mediated immunity, the individuals are at risk of Aspergillus, HSV6, herpes simplex, PML, Epstein viruses related lymphoproliferative disorders, and varicella zoster virus. More than 6 months, the common organisms includes varicella zoster, CMV, PML, and Epstein virus. Now we will see evaluation. We will evaluate and manage see the patients with classical specific infections like cryptococcal meningitis. Cryptococcus involvement of central nervous system is usually after a hematogenous spread from the lungs, which is the most often the primary site. The pulmonary involvement with severe pneumonia, dermatological manifestation like papules with maculopapules nodules, and a positive blood culture may provide a clue to diagnosis of CNS cryptococcal meningitis. The disease can have either meningeal or a parenchymal involvement. The meningeal involvement in the form of meningitis and a parenchymal involvement in the form of cryptococcomas. It can also involve the perivascular space, leading to characteristic appearance of soap bubble appearance with a gelatinous pseudocyst giving a soap bubble appearance, commonly involving the basal ganglion. The gold standard for diagnosis is isolation of the organism on fungal culture. Indian has been superseded by serum and cryptococcal antigen for the diagnosis. And the treatment of cryptococcal meningitis includes amphotericin B and flucytosine for at least 2 weeks, followed by fluconazole maintenance therapy. This is the brain MRI showing classical soap bubble appearance because of dilated perivascular space leading to gelatinous cirrhosis formation and characteristically involving the basal ganglion and structures. Next, Listeria, which is a food-borne gram-positive facultative intracellular organisms commonly affecting individuals commonly affecting infants, elderly age, malignancy, alcohol use is associated with immunosuppressive therapies. The most common presentation is a patient like a meningitis, and it can also cause involvement of brainstem and cerebellar involvement, leading to rhombic encephalitis and cerebellar signs. Diagnosis is established by via Listeria, CSF Listeria PCR or culture, or by a blood culture with compatible CSF profile and clinical features. Here we can see the MRI, the FLAIR images showing focal hyperintensities in the midbrain and right basal frontal and temporal lobes. With the post-contrast T1 images showing unilateral ring enhancing lesions in the midbrain, thalamus, and temporal lobe characteristic of an abscess associated with ischemia. Candidiasis, Candida meningitis is a rare and almost always occurs in the presence of invasive candidiasis, and it is mostly seen in patients with neonates, hematological malignancies, and post-transplant patients with on immunosuppression. The diagnosis is established via confirmation of systemic candidiasis with elevated CSF beta 1,3 beta G glucan is suggestive of a CNS infection. On imaging, usually there are multiple microabscesses in the gray-white macular junctions involving the gray-white macular junction, basal ganglion, and cerebellum. It can also cause a hemorrhagic component on SWI due to presence of myocardial aneurysms associated with candida. The CSF candida infections are treated with amphotericin B and flucytosine, followed by an azole for maintenance therapy. Echinocandins that includes caspofungin or micafungin should be avoided given its poor CNS presentation. TB has already been discussed in details by Sir. In CMV encephalitis, it usually presents within 1 month of transplant, and it can involve the entire neuroaxis from brain, spinal cord, nerve roots, or eyes. Symptoms are variable and usually present as a subacute presentation with subacute cognitive changes over weeks or months. CMV encephalitis should be considered in patients with associated colitis, esophagitis, or retinitis. It can also cause radiculitis or polyradiculomyelitis, and it usually presents more than 100 days of transplant. The features include early bowel bladder dysfunctions, pain, paresthesias, hypotonic weakness, and reduced reflexes. The diagnosis is established via CSF CMV PCR, and a high serum CMV PCR correlates with a greater likelihood of invasive infection. This is a MRI showing characteristic ventricular dilatation with ventriculitis, which is common in patients with CMV related, characterized by periventricular, subependymal, and ependymal enhancement on T1 post-contrast images. And differential between this includes the CNS lymphomas that usually has a mass effect, but CMV cryptococcus doesn't have a mass effect with it. The next infection group is HSV6 encephalitis. It usually presents 2 to 6 weeks after transplant, and most often it is involved in the stem cells. It is characteristically seen in patients with stem cell transplant, and it involves the limbic system and is known as post-transplant acute limbic encephalitis. So diagnosis is established by CSF HSV6
Darshan,
PCR.
your slides are not changing.
Yes.
Last was this cytomegalovirus.
Yes, sir.
It has
Now,
changed.
sir,
Now it is changed. Yes.
you-
But
so human herpes 6 virus encephalitis, it is usually seen 2 to 6 months after transplant. It is most commonly seen in patients with stem cell transplant, not associated with solid organ transplant. And it involves classically the limbic system, known as post-transplant acute limbic encephalitis. The diagnosis is established with the help of CSF HSV6 PCR levels, and the patient the characteristic imaging finding includes non-enhancing T2 hyperintensities on the bilateral medial temporal lobe and limbic structures, and it can be normal in 30% of patients in early infections. So HSV6 encephalitis is treated with postcardiac or ganciclovir. Cidofovir may be used in patients who do not tolerate or who do not respond to the postcardiac or ganciclovir. And patients with HSV6 encephalitis are at high risk of seizures, and we should have a low threshold for EEG monitoring because of limbic encephalitis and dyselectrolytemia associated with HSV6 can precipitate seizures. The Levipil is a favored agent for anti-seizure medication. Varicella zoster virus encephalitis or vasculitis. It is mostly common after immunocompromised patient. Other manifestation after a primary infection includes involvement of cerebellum with cerebellar ataxia like features and meningococcal meningitis, transverse meningitis, and aseptic meningitis. Manifestation of secondary after a secondary reactivation includes neuritis, that includes herpes zoster ophthalmicus or Ramsay-Hunt syndrome, myelitis, or rarely brain stem because of brain stem encephalitis. Characteristic varicella zoster vasculitis can cause ischemic infarction of brain and spinal cord, as well as aneurysm with subarachnoid hemorrhage and cerebral hemorrhage and dissection. The reduced ratio of serum to CSF varicella zoster virus IgG is preferred for diagnosis of VZV encephalitis. VZV can also cause myelopathy by various mechanisms, mostly vasculopathy causing spinal cord infection or direct viral infection of spinal cord, or post-infectious as a part of post-infectious inflammatory process. Characteristic imaging includes T2 hyperintense lesion involving the gray-white matter junction with associated diffusion restriction. And it can also cause stroke with diffusion restriction involving the white matter more than gray matter, and multiple vascular categories can be involved. This is the characteristic VZV associated myelitis in patient with post-transplant patient, and we can see T2 hyperintensities along the cords suggestive of myelitis. Herpes simplex virus encephalitis. The diagnostic, the CSF and serological diagnostic includes CSF HSV PCR, which is highly sensitive, with a sensitivity of 98% and 94% specificity. The MRI includes T1 iso-intense and hypo-intense lesion with the T2 hyper-intense lesion of temporal lobe, limbic system, and orbital frontal lobe. In a patient with immunocompromised brainstem involvement with brainstem encephalitis can also be seen. The spinal cord involvement is more often seen with HSV2 as compared to HSV1. The virus can reactivate in the sacral spinal ganglion and cause inflammation of corresponding dorsal roots and adjacent spinal cord known as Ellsberg syndrome. BKV virus, it is a polyoma virus most commonly associated with post-transplant nephropathy or hemorrhagic cystitis in renal transplant patient. It can also reactivate in patient with immunocompromised patient and can cause meningoencephalitis. The diagnostic criteria includes CSF, BK virus PCR, or PCR cerebral tissue is used for diagnosis. T2, the imaging characteristic includes T2 hyperintensities involving the limbic system. Now we will look at the focal brain lesion in patient with immunocompromised therapy. The first being the progressive multifocal leukoencephalopathy. It is caused by reactivation of latent JC virus, causing infection of oligodendrocyte. And presentation is subacute presentation with cognitive and personality changes, aphasia, weakness, and visual field effects. The diagnosis is established when characteristic MRI findings are supported by positive JC virus, PCR, or histopathology. Serum JC virus antibody index predicts the risk of PML in patients on natalizumab. So this is the MRI showing a large concurrent asymmetric involvement of bilateral cerebral peduncles extending into a cerebral hemisphere associated with T1 hypodensities and extensive asymmetric concurrent T2 flare hyperintensities involving the cerebral white matter. So the treatment includes immune reconstitution through reduction or discontinuation of immunosuppressive medication. And natalizumab, if the patient is on natalizumab, it should be immediately discontinued. Cerebral toxoplasmosis is an opportunistic infection caused by parasite Toxoplasma gondii. Infection should be considered in patient presenting with one or multiple ring enhancing lesion with seropositive for positive IgG positive for Toxoplasma. It has predilection for the Toxoplasma has a predilection for basal ganglion. Diagnosis is established by CSF Toxoplasma gondii PCR. Here we can see the CT plus MRI images of patient with CNS toxoplasmosis. The CT shows a hypodense perilesional vasogenic edema, and the MRI shows T2 flare dark lesion surrounded by a bright perilesional edema, and T1 post-contrast images shows multiple nodular ring enhancing lesion at gray-white matter junction with a eccentric target sign. The treatment includes combination of sulfadiazine and pyrimethamine, and it can be combined with leucovorin to prevent hematologic toxicity. Most of the radiological and clinical improvement occurs after 5 weeks of empirical treatment. Patient who shows no improvement, biopsy may be considered to evaluate for primary CNS lymphoma. So primary CNS lymphoma, it is a B cell non-Hodgkin lymphoma associated with EBV related B cell non-Hodgkin lymphomas commonly involving the brain and the spinal cord. The diagnosis is established using CSF analysis, which includes cytology, flow cytometry, EBV, PCR, and immunoglobulin heavy chain gene rearrangement studies. Differentiation between primary CNS lymphomas and toxoplasma can be done using slit lamp examination, which can reveal toxoplasma chorioretinitis or vitreoretinal lymphomas. Even if SPECT or PET scan can be used, in which toxoplasmas are hypometabolic and lymphomas are hypermetabolic. This is a MRI image showing large T-cube dark with T1 post-contrast homogeneous avid homogeneous enhancement with central necrosis in an immunocompromised patient. It usually crosses the midline at corpus callosum and crawls along the ependymal surfaces of the lateral ventricles. Treatment includes high-dose methotrexate, which is the backbone and is the initial treatment, and corticosteroid may be added after the diagnosis is made. Cerebral aspergillosis usually it presents usually the CNS involvement occurs after the hematogenous spread to CNS from the primary source of pulmonary source, or it can also directly spread to CNS via paranasal sinuses, where it manifests as invasive fungal rhinosinusitis. The aspergillus rarely present with headache and meningismus, and often present with non-specific findings such as fever and altered mental status. CSF galactomannan antigen has a sensitivity of 88% and specificity of 96% for diagnosis. And Aspergillus PCR also can be used with a sensitivity of 75% and specificity of 98%. However, the definitive diagnosis is often made using require a histopathological confirmation. These are the characteristic brain abscesses associated with a CNS aspergillus, which is classical ring enhancing lesion with slight diffusion restriction on the peripheries. CSF aspergillus can also present as a stroke with involving multiple small vessel perforators, and it can also cause subarachnoid or parenchymal hemorrhage, which can be seen on SWI. Nocardia. It usually present after 1 to 6 months after transplant, and patient with associated skin manifestation like pus-filled blisters, ulcers, abscess, or cellulitis with pulmonary or ocular involvement. We should suspect nocardia in this patient. And diagnosis is established by CSF bacterial culture, but biopsy is often needed for final diagnosis. Trimethoprim sulfametazole is used as a treatment for nocardia. The imaging characteristic includes multifocal T1 hypointense, T2 hyperintense with diffusion restriction lesion with thick wall of surrounding ring enhancement. So conclusion, neurological infection in patients on immunomodulatory therapies are common and can have significant morbidity and mortality. Awareness of this condition is a key because many may be treatable and reversible with early recognition. Diagnosis is challenging because of decreased immune response that can lead to atypical imaging or laboratory finding. Next generation sequencing of CSF is promising approach for unbiased diagnostic evaluation in these patients, but it is less sensitive with a longer duration of infection or in condition more dependent on serology for diagnosis. These are the next generation sequencing BioFire meningoencephalitis panel, which includes 6 bacteria, 7 viruses, and 1 fungus. Thank you.
I'm giving a prediction that if we ask Dr. Yash to give the same topic 5 years from now, he'll have to talk for 1 hour because the number of drugs are going up so exponentially. So we're going to get more and more complications from more and more medication. So it's going to be a very, very tough topic for us to manage as the years go by. This, however, has been a good introduction. Azhar?
Yes, sir. Hi. Hi. Very good, Yash. Very nicely done by Yash. He's worked really hard for this. And so, sir, like we were speaking that definitely the sensitivity and specificity of the individual tests is much more. But I think here, since the net is so wide in the first 1 month or 3 months post a transplant or something, here is, I think, where these panels are of more use. Because here it's a very wide spectrum. It could be a bacteria, fungus, parasite, absolutely anything, and so many of them.
Well, Rakesh, you want to say something?
I think I fully agree, Azad. When you have a typical suspicion of a disease, then you can always ask it, I think, as a separate test. But when the net is very wide and you just want to have some hint.
Azad, are you going to send the question in?
Yeah, panels are very useful.
Yes.
Correct.
So this has been a great morning. 4 hours and 10 minutes of sustained neuroinfection. It has been a feast with Dr. Karthik opening the evening on COMA and TB HIV combination. Amna spoke very well on approach, and she has covered every aspect of clinical approach. Then my favorite argument against all the Indian students of neurology, they're complete experts in McDonald classification, diagnosis of multiple sclerosis, classification of modified McDonald classification, the diagnosis. But they're very weak in so-called Indian diseases like tuberculosis, rabies, and leprosy. And today I'm happy to tell you guys that whether Chandrasekhar or Atish or Darshan has proved me wrong. It's a masterful presentation on what is commonly seen in our OPDs all over the country. They've done a wonderful job in these 3 disorders. The only thing that was missing, one of my favorite disorders, which unfortunately you people are not seeing because of public health issues, is tetanus. We used to see a lot of tetanus. JJ Hospital used to have a huge ward. And we used to see in the neurology ward, where the physician used to miss the so-called focal tetanus. You read about it, it's of interesting. And we have seen any number of patients in our training in neurology. But I know you don't see it anymore, but just for your interest, since your masters now are TB, rabies, and leprosy, just get a little bit of exposure into tetanus, clinical management, and clinical presentation of generalized tetanus and focal tetanus. Right? Thank you so much.
Thank you, everyone.
Does anyone else want to say something? Rakesh, yeah, waiting.
I think that it was very well covered in 4 hours.
Absolutely.
And I think even if we retain around 30-40%, it will make our life much more easier when we deal with infections. Thank you so much. Thank you
guys. Bye-bye. Have a good day.
Bye.
Have a good Sunday. Enjoy. You deserve the rest. Yeah.
Bye.